indicators of oxygen. So this is obviously not sound. So industrial machinery, transportation, construction, and social device. So we divide it into auditory and non-auditory. Okay. So there whatever the is get effects and control of noise pollution. Okay. So ventilation. This one is written question get clear. Okay. Now we have question. Question get சொல்றேன் ஏன்னா உங்களுக்கு எங்க வாய்ப்பு அப்புறம் சார் சொல்லி அதனால படிக்கலாம் சொல்லிடுவாங்க. ஓகே. ஸோ வென்டிலேஷன் ஆப்வியஸ்லி டைப்ஸ் ஆஃப் வென்டிலேஷன் என்னன்னா நேச்சுரல், ஆர்டிஃபிஷியல் அண்ட் பேலன்ஸ் வென்டிலேஷன். நேச்சுரல்னா ஆர்டிஃபிஷியல். ஓகே. பேலன்ஸ் தான் there are some specific machineries. So, உள்ள இருக்க unwanted எல்லாத்தையும் கரெக்டா பேலன்ஸ் பண்ணும். ஓகேவா? Thank you. Any doubts? Sir, Prabhagan sir, உங்களுக்கு education sir. Doubts? இல்லையா? அப்ப இந்த சோஷியல் கேர் ப்ரெசன்டேஷன்ல என்ன கிளிக்கறதா ஆன்சர் பண்ணிட்டீங்களா? ஃபைனல் கேக்குறாங்க. இல்ல ஆன்சர் பண்ணிட்டீங்க. Thank you.
I would like to thank Dr. Jeffrey Chanu sir for delivering such an insightful and engaging lecture. Thank you, sir. Now I would like to call upon Dr. Prabhakaran sir to felicitate Dr. Jeffrey Chanu sir for his wonderful speech.
Next speaker and
Now, I would like to call upon Dr. Zoonotic, sir, who is a professor and head of Department of Community Medicine, bringing nearly 2 decades of experience in medical education and public health with an MD in community medicine. He has taught undergraduates for 19 years and postgraduates for 12 years, shaping the next generation of healthcare professionals. His research career spans 17 years with an impressive portfolio of 31 publications, reflecting his deep commitment to advancing community health through evidence-based practice. Dr. Tirunakara's leadership and academic contributions make him a respected voice in the field of preventive medicine and public health. Welcome, sir.
Highlight. ಇದು ಆನ್ಲೈನ್ ಆನ್ಲೈನ್ ಪಾರ್ಟಿಸಿಪೆಂಟ್ಸ್ try to use this mic online video.
Good morning, everyone. At the outset, I would like to thank Dr. Prabhakaran, Head of the Department Community Medicine, Tagore Medical College. My senior friend, Dr. Selvaraj sir, is here. Morning, sir. Dear students, those present in the online, administration and management of Tagore Medical College, thanks for the opportunity. I was like talking with Prabhakaran, like those days, how it used to be. The park editions, only pitch black, and we have no other book to read. All those things were there. Like things are different now. You have the recent edition 28th, which is much more colorful. I saw many of them are already reading. Tested வச்சிருக்கீங்க பின்னாடி எல்லாம் பார்த்து என்ன பண்ணிட்டு இருந்தாங்கன்னு சொல்லிட்டு வேற ஏதோ சீரியஸா படிச்சுட்டு இருந்தாங்க, right? And you have so many avenues and options available where you can have this kind of revisions. A lot of online material sources are available which you can go through, and your exams have become really easy, right? So time given is 45 minutes and the topic is very voluminous. I know one component of each of this could be for 45 minutes or more. For example, entomology, if I start, just the mosquitoes will require one session, but the topics given are entomology and arthropod-borne diseases. Arthropod-borne diseases will include malaria, one session not enough, dengue, likewise. Each one is a big topic. So what I have tried in this particular 45 minutes is expose you to some of the questions with answers also. It is available. Thing is, you have to realize that you have to prepare in such a fashion and have to read more also. Another thing is malaria and all these topics you are not taught only in community medicine. You will be learning in medicine, microbiology, pathology, every other subject also. So it is going to get reinforced. The one component that will get added here is the preventive aspects and the program related aspects. All right. And the first few slides, I would like to pass on some information. I think you will appreciate it is relevant also. I hope you would have seen this competencies table. This curriculum volumes are available, which can be downloaded from NMC websites. So which has information like, competency is an observable, measurable thing. Any skill that you are doing that should be able to, that should be measurable so that they can evaluate you also simultaneously. Screen மேல வரதோ. All right, I will use the arrow. காமிக்க முடியல ஸ்கிரீன் ரைட்ல வருது. அப்படின்னா மைக்ல வர மாட்டேன். Actually, I am sure it is visible to at least first few rows. You can look at the curriculum book which is downloadable also. The first one is the competency number, then there will be the competency itself. The next one will know the level of competency, then the domain, whether it is a core one or otherwise, and how the topic has to be taken, whether it has to be taken as a lecture or a small group discussion, and what are the departments that needs to be integrated. This type of material is available, which you all should be familiar. And again, if you go to page number 47 of volume 2 of the curriculum book, that is where the community medicine competencies start. I have just given the environment alone for you to just see. And if there are only 8 competencies under the topic environment and health. Okay. I know it is very voluminous, very difficult to cover entire community medicine, and most of us don't know which one to read first. All those difficulties are there. To make things easy, I want to suggest this thing to you. Go through the competencies that is there in the curriculum book. Each chapter will have certain number of competencies, and as a question paper setter, the experience what I have is when the universities send us material for picking up questions, they will ask us to write. The question comes under which competency, which page number, which edition, all those stuff. Okay. The clue is questions will mostly come from within these competencies only. So instead of reading everything and wasting time, maybe you can concentrate on these competencies and what is mentioned under each competency that is likely to come as exam questions, whether long answer, short form, or MCQs. Okay, that point I want to stress. If you look at the last 3, it is about entomology. What are the different insects that transmit diseases? What are the public health measures that can be employed to control them? All those kind of things. In that point of view, these topics have been included for my session. And another thing, when you go to MGR University website, even your college comes under Tamil Nadu Dr. MGR, click this link. This gives old question papers. This is available in the archives section from 2001 onwards. Okay, you can go through this part and maybe revise the last 5 years questions and be familiar so that things will be much more easier also. And this another link is, this will give what are the different topics in community medicine that are must know, nice to know, and desirable to know. Okay. Whether you know this before or not, any question paper anybody is taking, 70% of the questions should be from the must know area, 20 from nice to know area, and the remaining from the desirable to know area. So if you are already familiar which are the must know areas, and if you prepare adequately, and there should not be any difficulty in scoring the necessary marks for passing, sometimes even you will be able to score much more also. Okay, these are the few things first I want to tell all of you. And one more time I would like to repeat, within 45 minutes, it's impossible for anybody to cover all the topics that's been given. So I have kept some like sample kind of questions covering all these areas. You may have to work for more. All right. Entomology, so small introduction. Arthropods means insects that have joined legs. And entomology is the study about insects. Medical entomology is study of insects of public health importance. All those which can spread the disease from one person to the another. I'm sorry about the quality of the projection. I don't know how much is visible. Maybe from here it is difficult for me. All right. And arthropoda consists of lot of classes, but we are going to see only about these 3: Insecta, Arachnida, and Crustacea. So Insecta and Arachnida will be found on land, and Crustacea will be found in water. Okay. So these 3 classes, and the insects can be classified into those which have the wings and those who do not have the wings. Questions can arise from this part also. That's why I made a mention here. So what is the difference? What if the insects have wings or if they don't have? Thing is, those insects which have wings can fly or move from their breeding places to longer distances and spread disease, whereas wingless won't be able to do. Look at this question. This is related to the content what I have already shown. Which of the following does not have wings? Anyone? Any answer? I think I heard the answer. Rat fleas. Rat fleas does not have wings. Okay, their body is divided into head, thorax, and abdomen. They are laterally compressed, reddish brown in color. Hair-like spines, which are arranged as combs, will be uniformly distributed. All of them will be directed backwards. Okay. Both male and female fleas will bite and transmit disease. Which disease rat fleas would transmit? Yeah, correct. Plague. So again, next part is about the transmission. What are the different types of transmission? Anyone? One answer is here biological. Biological has 3 subtypes, and the other one will be mechanical. For mosquitoes, biological transmission will be that. Coming slides, I will be showing more information. So in mechanical transmission, there is no development change in one form or increase in number. Okay. Example is housefly. It is a hairy insect. It usually frequents between food material and fecal material. It does not differentiate between the two. By virtue of hair present all over its body, what it does is, when it sits on the fecal matter, all the contaminated material will get stuck onto it. And when it sits on the food, it will deposit all of them on the food material. Okay, and usually it will be attracted towards bright colored foods. Okay, and another thing about housefly is it cannot eat solid foods. So when it sits on solid material, from its proboscis, it would secrete some juice which will liquefy the solids. In the process, it will deposit all the bacteria, which is the bacteria Salmonella typhi on the food material. Okay. Another behavior of the housefly is, as it eats, it also defecates. So what it does, bacteria from the lower GI will be again deposited on the food material. Okay. What we do, we are also attracted towards that bright colored, probably sweets and other stuff, and we go and eat unknowingly that this stuff is happening, and it will result in disease. Okay. So in mechanical carrier, there is no multiplication or no change in form. It only carries the infective material from one place to the other. Okay. And housefly is the example. The next one is the online location. Biological transmission, you have 3 things: propagative, cyclopropagative, and cyclodevelopmental. Propagative transmission, there is increase in number, multiplication. Example again is, any example?
For 1 week, ஏசிலே போயிட்டேன் சார் கார்ல போகும்போதே ஒரு 2 தும்முனா இல்ல நான் தும்மல் வந்து அப்பதான் ஆரம்பிச்சது. ரிட்டர்ன் வரும்போது ரொம்ப கண்டினியூஸ் ஸ்னீசிங் இருந்துட்டே இருந்தது சார். வரும்போது ரன்னிங் ஹவுஸ் ஆயிடுச்சு. ரிட்டர்ன் வரும்போது எடுத்து 1 hour பெறும்போது போயிட்டு ரிட்டர்ன் காஃப் அப்ப இல்லவே இல்லை சார். ஃபீவரும் இல்ல. சாட்டர்டே மதியம் வந்து மைல்டா டெம்பரேச்சர் இருந்துச்சு.
You have propagative, cyclopropagative, and cyclodevelopmental. Propagative transmission example is rat fleas. So the causative organism does not undergo any change in form. There is no development, but there is only increase in number. Example, plague bacilli. Plague is caused by Yersinia pestis. The nature of the Yersinia pestis is they will produce sticky mucilaginous colonies. Okay. I have one more slide in the end. I will show you, explain you that about the block flea mechanism there. In plague bacilli, there is only multiplication. Then the next one is cyclopropagative transmission. Here, the organism undergoes a developmental change. It gets converted from one form to the other. There is also increase in number. The example is malaria. Both development as well as multiplication will take place in cyclopropagative transmission. And in the next type, cyclodevelopmental, there is only change in form. larval stage, first stage to second stage to filariform larva change will be there, but there is no increase in number. Filariasis is the example for cyclo-developmental transmission. Okay, I will look at the next question. Streptypus is transmitted by? Yeah, I had the answer correct. Thrombiculate mites. Good. KFD is transmitted by? Yes. Yeah. Ticks. What are the types of ticks? Soft tick and hard tick. Yes. How do you differentiate hard tick and soft tick? Importance of entomology is you are going to have one microscope, sometimes more than one also, definitely as spotters. It could be asked in short note question, sometimes a part of long answer question also. So you have to know entomology. Types of ticks, soft tick and hard tick. How do we differentiate hard tick from soft tick? Hard tick because it will have a chitinous exoskeleton that will give its proper shape, and the head or the capitulum will be present in the anteger. I have a picture somewhere else. I will tell you during this time. Japanese encephalitis is transmitted by, without options, you should be able to tell which mosquito. Culex. Culex, Pulci, Fasciatus, Tritania or Endus. When you have two, then you will have to select one. Where does Culex mosquitoes breed? Dirty water collections. But in relation to filariasis, what is the scenario? Filariasis is regarded as a rural disease. We all know that in rural areas, okay, dirty water collection will be there. What will be actually more? Ponds. Is that what you are telling? How do you define a rural area? Yes, you can attempt some of the. I have tried to do lip reading also. You tell, I won't be able to hear, but still I can get the clue. Most of the people in that area, when their predominant occupation is agriculture, then it is a rural area. When I say agriculture, what will be there in that part? Irrigated fields, paddy fields. So in those irrigated paddy fields, these Culex mosquitoes will breed. That is how they are at the risk of transmitting filariasis. All right. It is Tritaniorhynchus. The other type of Culex is, three species are popular or common. Yes. Vishnui. One more. I should have asked other types. Vishnui is also there. Fatigans. Fatigans. Okay. Vishnui, Fatigans, Tritaniorhynchus, and Pulci fasciatus. Okay. This kind of tables are available in entomology section, which you should be familiar. Public health importance means what are the diseases transmitted? The Anopheles transmits malaria and filaria. Culex, again filariasis, Japanese encephalitis. At least you have to remember two each so that you will be able to write in your spotter section. And it is yellow fever, dengue fever, Rift Valley fever, Mansonia, again filariasis and chikungunya. Some of them may not be in India, but these are the common ones, right? Okay. Moving to the next section. Which anti-larvicide can be used in drinking water? Paris green? Okay. Whenever there is a question on insecticides, what we are supposed to do as short notes? How will you approach it? I think that is also part of my session, isn't it? Yes, you have to write the classification, isn't it? Broadly, how they are classified. That particular insecticide comes under which class? What type of poison it is? What is the mechanism of action? What is the dosage required? What are the probable side effects it can produce. If you can answer all that, then you will get the bars. And mostly it may not be a separate long short note question. Maybe it will be split into two and it will be one part, because all these content are not worth more than 2 marks. Okay. If you prepare systematically, probably you will be able to answer. Fine. Okay, now it's not Paris green. I think 4 group பிரிஞ்ச ஆளுக்கு ஒன்னு சொன்னா கூட ஏதோ ஒரு group கரெக்ட் ஆயிடும் இல்ல. பின்னாடி இருக்கிறவங்கள நான் அப்பவே சுத்தி வரும்போது பார்த்தேன். ஆக்சுவலா அவங்க யாரும் இந்த ஹால்லே இல்ல, வேற உலகத்துல இருக்காங்க. And this is routine in any class. Yes. I think திரும்பவும் ரெஸ்பாண்ட் பண்ற அவங்களே தான் நான் கேட்டுட்டு இருப்பேன்னு நினைக்கிறேன். Can we pause? Okay. நாளையும் ஒண்ணு யார் யார் கை தூக்குறீங்க next round I am going to ask like that. Can we pause? It is. Professor is, again you have to tell the classification, whether it is an organochlorine or carbamate or synthetic pyrethroid or OP compound. What is it? நேரம் எல்லாருமே புக் வச்சிருக்கீங்க, அந்த பேஜ் எடுத்திருந்தா கூட you would have answered more. It is a carbamate. All right. So this table is there in PARC. So when there is a short note, what you should do is write the broad classification, contact poisons, stomach poisons, and fumigants. In that, which one is natural, which one is synthetic. Among the synthetic, whether it is an organochlorine or an organophosphate or carbamate. See, there is a list. Each category has so many, but only few are very important. Many would have developed resistance or not in use. Only those, if you remember, it will be sufficient. All right. Okay, but these are very common things which we are coming across everywhere, but maybe we would not have registered the answers. For prevention of fly breeding, the insecticide best suited for spraying on garbage collection is. Any idea which one is? Probably you may know the name. Here it is mentioned with a different name. DDVP. What is that? How is it otherwise called also? I think somebody is telling. That's correct. Dichlorovas. So DDVP is nothing but dichlorovas. Actually, mosquito coils. We are using mosquito coils. No? They contain what? Pyrethroids. Yes. What are the active principles in pyrethrum? Some 2 types are there. Side by side book line check பண்றீங்க, சில பேர் phone line பாக்குறீங்கன்னு நினைக்கிறேன். All right. Anyhow, end of the day we want you to know the answers. Familiar இருக்கணும் அவ்வளவுதான். Right? Eggs of which of the following are laid on the undersurface of certain water plants like Pistia? There are 4 species of Anopheles, isn't it? What are they? 4 types of mosquitoes. I'm sorry. ஒன்னு நானே சொல்லிட்டேன், Anopheles. Then, if you know the breeding places of mosquitoes, then you will be able to answer. Anopheles will breed in. I think I'm hearing the answer. Clean running water. Culex we already discussed. Dirty water collections. What about Aedes? Artificial water collections. Okay. Then what is the 4th type? I'm not mentioning the name. அதுதான் இதுல breed out. Mansonites. Yes. Okay. இது போட்டு வச்சுட்டு கேட்டா ஈஸியா சொல்லியிருந்திருக்கலாம், but I wanted you to think also. Right? It is Mansonites. Okay. Type of formulation in which the insecticides were. What is IRS? IRS stands for. What are the 2 types of spraying? சொல்லுங்க, அதெல்லாம் ஈஸியா தெரிஞ்ச விஷயம் தான். நீங்க எல்லாம் பிஜி சம்மா. IRS stands for indoor residual spraying. So when you spray inside the house, it has to have a lasting effect for at least 6 months. We can do it on a routine basis daily. The other type of spraying is IRS போக இன்னொரு type of spraying என்ன? இந்த வடிவேல் காமெடியில வருமே, அந்த ஒரு மெஷின் அடிச்சுட்டே போவாங்க. சாரி, ஸ்பேஸ் ஸ்ப்ரே. Space spray. So in what form this spray will be there, insecticide will be there, whether it will be an emulsifiable concentrate or concentrate liquid, wettable powder or aerosols. Wettable powders, all right. So mosquitoes that prefer feeding on human blood compared with animal blood are called. It is a straightforward question. We should be knowing the answers. You don't need to prepare for this. Anthropos means human, no? Zoona animal. Adile irukku answer avlo. So it is anthrophilic. Phobic na against, liking na philic. So the answer is anthrophilic. Okay. So insecticide impregnated strings, cords and wires hung from ceilings. For in which insect we use this kind of cords, ribbons hanging? Tsetse fly, Simulium fly, bed bug. இது எதுவுமே கிடையாது. House flies, இது பார்க்க முன்னாடியே you should be able to say. Why we do that? Because they have the tendency to hang on, alight on hanging objects. That is why we use this. House flies. So what chemical will be used in those cords? I think that question already came. In which vector only the larval stage can transmit disease? What are the intermediate stages in the life cycle of insects? Egg, larva, pupa and adult. In some names also will be there. All right. So only the larval stage will transmit disease in thrombiculite mite. Thrombiculite mite will transmit what disease? We had a question already. Streptypus. Fever of 1 week duration in India, differential diagnosis should include streptypus. You remember, learning does not happen compartmentally. Whatever you are learning, you have to remember and use everywhere. Okay, that part also you should know. Okay, this question I was already asking, how will you differentiate between hard tick and a soft tick? The light மேல அடிக்க முடியல. Hard tick will have chitinous exoskeleton that will give a proper shape for it also. Okay, and if you look at the anterior, there is a head. If the head is in the anterior and there is a chitinous exoskeleton, then it is a hard tick. Both of them will have 4 pairs of legs. Okay, whereas you look at this soft tick, does not have a exoskeleton and you cannot see the head also in the anterior. When it is turned to the ventral side, you can see the subterminal head or otherwise called capitulum. I think Selvaraj sir is appreciating. Idella Ramachandra product. So we know entomology thoroughly taught by our Professor Dr. Palani sir. At this time, I would like to remember him and thank him also. Hello. What about ticks? How dangerous are them as a vectors? இப்போ ஒரு சென்சேஷனல் டாபிக் வேற போயிட்டு இருக்கு. நீயா நானால எல்லாம் ரொம்ப பாப்புலரா வேற ஆச்சு. How many of you like pet animals? How many of them of you are already having some? I want to ask one. Which one? Dog or cat or both? Cat. So usually these ticks will be there on these dogs and cats. Actually, ticks will be present in the outside environment, grasslands, Anila. When these dogs or cats go there, this will get attached to them and they will bring these inside our domestic areas, isn't it? So among these soft ticks and hard ticks, hard tick will be continuously attached to the host and it will be continuously feeding. Whereas soft ticks, they can attach to the host, take a blood meal, separate up to 1 year also it can survive and then transmit disease. And all stages and all body parts and all fluids of these ticks can transmit disease. Okay. For PGs, the reasons for ticks having an enhanced vectorial capacity, that is a separate question which you should know. For real at the point of the for UGs, if you write just ticks, it is sufficient. And also you should know which are the diseases transmitted. Spotters, I think, sir, the ticks slides. Hard tick. Mostly it will be hard tick. Okay, what you should write is 4 pairs of legs, body not divided into head, thorax, and abdomen. It is used as a single unit, oblong in shape. It is present in the anterior. So these are the points you should be writing. And disease is transmitted very easy. Tick, typhus, paralysis. But when we correct during exams, we could see all kind of answers. Tick, lice, lice, rat flea, thing is, you don't at least spend some time trying to remember. So KFD, the question already wanted to repeat, transmitted by KFD stands for Kaisunur forest business. Where is this Kaisunur? Which Karnataka, Shimoga district of Karnataka. So which are not transmitted by Aedes. So it is better you can tell which diseases are transmitted by Aedes aegypti. Forget about Aegypti, Aedes mosquitoes. First one, dengue. Yeah, across yellow fever, chikungunya. Abro. So, J, the question already came. It is transmitted by Culex mosquitoes. Where do they breed? Don't think I am asking repeatedly. Exam la vandha maati sollitringa. Adha prachana. So reinforcing. Japanese encephalitis. Is it a big problem now? If you are actually, I suggest all of you should follow what is happening every day in the community. Actually, recently what we experienced is many of our known non-medical people, those work in our college who have children in schools, they were all sent one letter for consent, whether they are willing to give JE vaccination for their children. So, அவங்க நம்மள தான் கேட்பாங்க, கொடுக்கலாமா வேணாமான்னு சொல்லிட்டு என்ன சொல்லணும் நம்ம? அந்த கொடுக்க போயிடாதீங்க அப்படின்னு சொல்லிருந்தோமா? They should advocate or not. So அதனால நமக்கு தெரிஞ்சிருக்கணும். இந்த டாக் கேட்ஸ் பத்தி இன்னொரு விஷயம் முதல்ல கேட்டேன். அது இப்ப எவ்வளவு பெரிய ப்ராப்ளமா போயிட்டு இருக்குன்னு. இல்ல? Actually, we have big responsibility. Whether we realize that or not, I don't know. The doctors meaning itself is teachers. You are supposed to know. நீங்க எல்லாம் இங்க இருந்து படிக்கிறது உங்க எக்ஸாம் பாஸ் பண்றதுக்கு மட்டும் கிடையாது. You should know things correctly and transmit or disseminate the information to the others. The more correctly you do, the community is benefited. Only then you will get the respect, right? இல்லைன்னா என்ன ஆகும்னா, யாராவது ஒருத்தர் இங்க வாங்க வந்து இங்க நின்று இப்படி திரும்பி பாருங்க. இப்போ இந்த கிளாஸ் ரூம்ல என்ன நடந்துட்டு இருக்குதோ அதே மாதிரிதான் நம்மளும் இருக்கும் சொசைட்டில. அங்கெல்லாம் வந்து யாருமே நிமிந்து கூட பார்க்கல. ரொம்ப நேரம் இப்போன்னு இல்லை, மேபி எக்ஸாஸ்ட் ஆயிட்டாங்கன்னு நினைக்கிறேன். It happens. Okay, plague is transmitted to human beings bite of which rat flea? Male or female? நிறைய பேர் ஃபீமேல்னு சொல்றீங்களா? Both male and female. Okay, mosquitoesல தான் வந்து female mosquito. Both male and female. So important species of rat flea for transmitting in India is Phenoxyla cheopis. Okay. So which clinical form of plague can be further transmitted from man-to-man transmission in plague could be easily done through which type? Pneumonic, because it is droplet infection. Buboes are usually they will be developed in the groin regions. Okay, black, it will rupture and release black color fluid. Close contact lerunda, maybe they will get it, but it takes time. From the rats, usually buboes will be developed. That will become disseminated into the blood, reach the lungs. From then it becomes pneumonic. When man coughs, it will easily spread. Pneumonic. This answer on the bubonic. This is the other one. It is bubonic. From rats, it is bubonic. This block flea mechanism, all of us should be familiar. I'll ask you this question first. Which is more dangerous? Completely blocked flea or a partially blocked flea? Yes, why? Sir, in the diagram. Yes. See, from mouth, like our esophagus, the rat flea has a proventricularis, and after that there is a stomach. I mentioned plague bacilli is Yersinia pestis, which can produce sticky colonies. The type of transmission in plague is, thank you, sir. What type of transmission is there in plague? Mechanical, in biological, propagative, cyclopropagative, cyclodevelopmental. Aduklam marmutinga. Propagative transmission. There is only increase in number. What happens? Once the rat flea takes a blood meal, Yersinia pestis will multiply and produce sticky colonies and become a ball-like. You can see that. And it will completely block the esophagus, proventricularis. The blood meal will not be able to reach the stomach. The flea will be starving. So until it is alive, it will be frantically biting, every time regurgitating plague bacilli into a different host and spreading the disease. When the block is partial, some amount of blood will be reaching the stomach. So the flea will be alive for more duration compared to a completely blocked flea. But still it won't reach, attain its satiety. So it will be biting more people for more time. Okay, that is why a partially blocked flea is epidemiologically more dangerous when compared to a completely blocked flea. Okay, if this comes in a short note, you should be able to write, draw a diagram and also write this part. Partially blocked flea is epidemiologically more dangerous. All right. Rift Valley fever is transmitted by, recollect the table. Which mosquitoes? Aedes. So which of the following vector-borne disease is found in India? I mentioned one statement also, Streptypus, right? Streptypus. Chagas disease, the other name, na? Which insect is associated with Chagas disease? What fly? Sandfly. It is called African sleeping sickness. All right. So fertilization between male and female gametes of malaria occurs in mosquito. Which part, body part of the mosquito? Stomach of the mosquito. Malaria is not found at altitudes of more than yes. Make a guess. Actually, I would like to recollect something that was told to me when I was a PG in Ramachandra. This was told by a pediatrics PG who was UG then. Community medicine from the strict department, 50% long pass from there used to be one brigadier, short person. 100% attendance எல்லாமே இருந்தாதான் எக்ஸாம்க்கே போக முடியும். அதுலயும் 50% கம்மியா தான் பாஸ் ஆக முடியும். ஸோ அவன்கிட்ட வந்து he was waiting for his turn வைவா. முன்னாடி இருக்கிறவனுக்கு அதே கொஸ்டின் தான், இதே கொஸ்டின். ஸோ அவன் வந்து சொல்லிட்டு இருந்திருக்கான், ஃபர்ஸ்ட் ஃப்ளோர் சார், செகண்ட் ஃப்ளோர் சார், தேர்ட் அப் டு ஃபர்ஸ்ட் ஃப்ளோர், செகண்ட் ஃப்ளோர், தேர்ட் ஃப்ளோர் அப்படின்னு. ஆன்சர் கேட்கல, ஆனா எக்ஸாமினர் டிஸ்அப்ரூவ் அவரு தான். அவன் ஏதோ ஃபர்ஸ்ட் ஃப்ளோர் செகண்ட் ஃப்ளோர் சொல்லியிருக்கான். ஸோ இவன் உள்ள போனோட இவனுக்கு அதே கொஸ்டின் கேட்டோன்னே தேர்ட் ஃப்ளோர் சார் அப்படின்னு. ஏன்னா ஃபர்ஸ்ட் 2 ஃப்ளோருக்கு இல்லைன்னு நம்ம சொல்லிட்டாங்க. இட் இஸ் 1800 meters. இந்த ஆன்சர்லாம் கொடுக்க முடியாது, ஃப்ளோர் வைஸ், மீட்டர் வைஸ் யூஸ் டு ரைட். So malaria transmission can happen through which route? One is mosquito bite. அதுக்கப்புறம் we screen for malaria on what occasions? All of the above? Yes, all of the above. So rapid diagnostic kits for malaria will detect what? Antibodies, antigens, both antigens and antibodies, antigens, right. Okay, most sensitive index for recent malaria transmission in any community is infant parasite rate. There are different indices, API, annual parasite incidence, ABER, annual blood examination rate, SFR, SPR, எல்லாமே தெரிஞ்சிருக்கணும். Alright. Benign tertian malaria is caused by tertian, quotidian நிறைய இருக்குல்ல, depending on the number of days on which fever occurs. Vivacities. Okay, for want of time I am rushing. Hypnozoites belong to which phase of malaria schizogony in humans? Huh? You have to know the life cycle. Okay, when the mosquito bites us, what will be injected into human? Yes, I will give you choice: sporozoites, scisons, hypnozoites, merozoites. Sporozoites. Immediately what will happen? Phagocytosis, most of them will be engulfed. The rest of them will reach the liver and they will become hepatic scisons. Okay, they will rupture and release merozoites. And merozoites, most of them will get destroyed, rest of them will enter the blood RBCs. Okay, that is pre-erythrocytic and erythrocytic, and afterwards it is exoerythrocytic. Life cycle, when you know, you will be able to answer this. Exoerythrocytic. Occult filariasis is caused by allergic manifestation. Good. In National Malaria Filaria Control Program, target is to bring down microfilaria rate to below 1%. So, what is this disease? KFT. Okay. Repeat vandirukku. This question has been asked several times. You can also expect. Which of the following rickettsial disease is not a zoonotic infection? Zoonosis is the next chapter actually. Murugan will take. This is related to one vector. That's why it has appeared here. Epidemic typhus is transmitted by இங்கெல்லாம் காமனா பண்ணிட்டு இருக்கீங்களா? Somebody will scratch, keep scratching here. Lice. காமனா பண்றீங்கன்னது லவ்ஸ் சொன்னாங்க, இது லைஸ். Epidemic typhus. Drug of choice for treatment and chemoprophylaxis for rickettsia is tetracyclines. Good. Which one is the correct pair? I think the order சொல்லணும். வந்துச்சு. It is, I'm sorry, lag வந்துச்சு. Phlebotomus argentipes, it can cause cholera, sir. Cause இல்ல, transmit. So which mosquito species primary urban vector for Bankruptian filariasis? Culex, Quinque fasciatus. முதல்ல வந்து ரூரல் ஃபைலேரியாசிஸ்க்கு என்ன பார்த்தோம் சார்? சார்ஜர், பேட்டரி லோ. இது ஆன் ஆயிருக்கான்னு பாருங்க. சரி, இதுல போட்டிருக்கு, ஆனா வருதான்னு தெரியும். The other species which we already discussed are Vishnuvai, fatigans, Triteria, or Incus, right? So which in sandfly control, which is more effective? Where will we find sandflies? Endophilic as well as exophilic. Exo is outside. Sandflies will be found where? Outside. Cattle sheds. And inside the house in where? In the cracks and crevices. Only when we know this, we will be able to answer. So you can answer. Inside the houses for sandfly control, we should use residual insecticide spraying because they will be found in the cracks and crevices in the houses. Okay, chicken mites transmits cryptypus. Infective stage to human is the question modale once. Larval stage. Okay. So which is the current sequence in the time na adhigama press panla path solunga. Mosquitoes. Metamorphosis is otherwise called life cycle. It is two types, complete and incomplete. Complete is when all the stages are there. Mosquitoes, the life cycle is complete metamorphosis. So what will be there? Egg, larva, pupa, and adult. All the four will be there. So the option is B. Okay, all the four stages will be there. Anopheles and Aedes eggs are usually laid singly. Culex and Mansonite. Culex and Mansonites will be laid in clusters. Anopheles eggs will have lateral air floats. That is the difference. Anophelini larva will not have siphon tube, whereas Culicini will have siphon tubes. So because the siphon tubes are there, they will be floating downwards. Okay. Whereas Anopheles will have only spiracles, so they are surface feeders. They will lie parallel to the water surface. Okay. What we are going to gain by knowing this information? Are the tube irunda enna thonguna enna illa flat irunda? I'll tell you the purpose. Suppose we are going to use larvicides. If we are going to deal only with Anopheles, so much concentration and so much penetration will be sufficient. But if you have to take care of Culex larva, it has to penetrate little deeper. Okay, Marty Senjona, it will be a waste of resource. We are learning entomology mainly for this purpose only. Right? Then pupa, Anopheles pupa will be deep comma and the tubes will be short and stout, whereas Culex pupa, ordinary comma with long and slender tubes. And morphology you will be already knowing. Okay. House index is 3, container index is 15, bread 2 is 30. What is the status? Is it high risk, low risk? For this, you should know each of those indices. Okay. Padikino is our Padikavende area. It is high risk transmission. The patient presents with relapsing fever after staying in a refugee camp. The hint is crowded area, refugee camp. The disease is relapsing fever. So which is the insect associated? Think one more time. Relapsing fever. So on the disease list there, epidemic typhus is transmitted by louse. Okay, this part is confusing, only you have to remember. So JE, the primary amplifying force. This particular animal will receive some strains from birds, some from mosquitoes, some it will also produce and mix and produce a new strain. Next time when the mosquito bites, it will pick up that and transmit it, which is this animal. Pigs. Pigs are the amplifying force. Good. So urban cycle involves what? In dengue, yellow fever. From the Mankabe monkeys, the mosquito will get the infection. When it comes to our peridomestic areas, it will bite man. Next what? From man, it will go to another man. Okay. So it is mosquito, man, man. Okay, the last slide, sir, last slide. I think 5 minutes left. How to approach short note questions? So you are all already experienced. First year, exam, but still, lot of problems we encounter when we value papers. So just in 1 minute, I would like to tell this familiar things. First, read the question. Question will be different. What is written there will be not connected at all. We have to do digital evaluation. You know, the strain is too much, 60 papers per day. And with the MGR University, things are really difficult. So many things you are supposed to take care. Answer to the point, what is asked. Nowadays, many people are trained in medical education. They ask very specific, exact questions. You try to answer only them. And instead of writing paragraphs and making it difficult for the examiners to read, you can write it in points. Okay? Then, wherever applicable, you can draw diagrams or use flowcharts. That is the purpose why I kept some diagrams and flowcharts also in this presentation, actually not required for me. Highlight important points. You can keep different color pens, okay? And some colors are not allowed. Please don't use them. You just check how it is looking in the paper. It will be the same on the screen also. So the same color will be there. Let it not be very light colors and let it not be very jarry also. Then you have to use headings and subheadings. When headings are proper, most of the time we don't read into the content also. It will be easy for you to score the 60 marks. Then the most important things, park manuals, Falcons, follow standard books. The reason is you don't know who correct your papers, both UG, PG. He will be prepared only from standard textbooks. And which is that standard textbook that is prescribed? Park only. And any notes that you have, that will have the layout of Park only. So it is better you read from Park. And when low marks is given, don't come and argue why it is given less. For me, I approach any paper in three ways only. The answer has to be logical, textual, what is given in the textbook, both. More marks. First 10% or 15% marks only. Bookler general answer and come and argue correct. So you will not get enough marks. So follow standard textbooks. Another big problem is Mati Kalamda. In the section question, please don't do that. You leave page and go, come back and answer, because simultaneously we have to go back and make entries. Please don't jumble. Recently, I had been to Pondicherry, art batch. I found it really very difficult. And every new answer you start from a fresh page. 70 pages. Start everything from a fresh page. That will be also good. And I wanted to keep this always present. Please write legibly. Okay. All the best to all of you. Again, thank you for the opportunity.
I extend our heartfelt thank you for taking time to be with us today, sir, and sharing such a valuable and interactive section. Thank you, sir. Now, I would like to call upon Dr. Prabhakaran, sir, to felicitate Dr. Tirunavasan, sir, for his wonderful lecture.
We have made for this competition.
ஆமா இப்ப அவன் அதெல்லாம் இது கேட்டு நீங்க கேட்டு யாரோ கேக்குறாங்க உங்களுக்கு ரொம்ப சரி சமமா பிரிக்கணும்
It's a tea break. Session starts in 10 minutes. Select. That's to come in. So next. எங்கம்மா கேம்பேரிங் ஒரு நிமிஷம்.
I'd like to welcome Dr. Murugan sir, who was the professor and head of Department of Community Medicine at Melmarvattur Adi Medical College and Hospital, with an MD in Community Medicine and advanced training through the ACME and Premier Fellowship from PSG Premier Regional Institute. He brings a rich blend of academic rigor and leadership. He has 14 years of undergraduate and 10 years of postgraduate teaching experience and has published over 20 papers in national and international journals. His administrative roles include serving a vice principal, PG and research committee convener and medical education unit coordinator, reflecting his deep involvement in curriculum development and institutional governance. Dr. Murugan's commitment to ethics, education, and community health makes us a dynamic contributor to the field. Welcome, sir.
ಇದೊಂದು ಸ್ಲೈಡ್ ಮಾಡಿಲ್ಲ.
Okay, good morning. And I'm Dr. Murugan. We'll have this session on zoonotic disease and surface infection. We have some 8 cases we have. We'll try to discuss it. Key points alone, let us see the key points on these topics. Okay, can you read me this case scenario and tell me what is this? What is it? Baby style of another brain, dog brain. Okay. What is this one? What is this one? Hydrophobia. Hydrophobia is the pathognomonic feature of rabies. What is the agent for rabies? Virus the virus. Okay, agent is a Lysa virus. Okay, agent is a Lysa virus. Hydrophobia is the pathognomonic feature. MCQ point of view, you see. In the patient is coming with a dog bite. In the what you are supposed to do? Bukla bakla 5 points are covered. Chuma keta photo. Okay. What is the next step? What is the next step? In the first step and wash panna. How to do that? Okay, you should wash it with running water. You don't wash panna. 15 minutes wash panna. Enna panna kuda. What you are not supposed to do? You should not do immediate suturing. Suturing panna kuda. Enna because you will bite and you will create nerve endings that will create the ascent of the virus, ascending of virus. So avoid suturing to 24 to 48 hours. So you can use virus-incident agents use panna. You can use BT. Antibiotics use panna. Eppa ARV kudukonu. When to give? Keep on. Just count up. Eppa ARV kudukonu. When to give? How to do that? How to do that? Every panna, every ARV could be decide panna. We have to categorize panna. We have to categorize. So we can divide them into 3 categories. One is touching, feeding. Second category is so if there is bleeding in the category, bleeding illana enna category. Patient is coming with the dog bite. Bleeding in the category, bleeding illana enna category. Bleeding is not there, it comes in category 2. If bleeding is there, another category. Now tell me, how will you manage category 2? Category 2 kenna panna porom? You are going to provide ARV. Okay, fine. Category 3 ke you are supposed to give what? ARV plus immunoglobulin. Visibility number here. Okay, provide. Column itself is one, row itself is not there. Okay, category 3. If category 3, you will be providing immunoglobulins as well as you will be providing vaccine. What is the regimen available? We have 2 regimens available. Okay, first one is following post-exposure prophylaxis. First one is essence regimen. You will be providing on 3 states 0, 3, 7, 14, and what is the last one? So here the leader. What is the last one? 28 days. 0, 7, 3, 7, 14, and 28 days. The second one is intradermal regimen, that is called as updated thyroid regimen. We are going to provide 03728 days. It's given intradermally. Now tell me, what is the difference? What is the difference? Intradermally, what is the one more slide? Row is sitting there. What you're supposed to do? You'll be providing 1 dose or 2 doses. So intradermally you are giving means you have to give 2 sites you have to provide. If you are giving the right arm, you are supposed to give it in the left arm also. 2 sites you have to give. So this is NR regimen, but this is post-exposure prophylaxis, intradermal and intramuscular. In a government college, most likely they will be giving all the colleges intradermal regimen. Post-exposure prophylaxis already vaccinated. Okay, so patient Baranga is coming in the dog bite. Last year, he has another dog bite. For then he has already taken the vaccine. On the situation, dose 2 doses, 0 and 3 days. Pre-exposure prophylaxis, you are having a high risk to have dog bites. Very risky veterinarian or you have a lot of dogs in your house. Okay, if you are having a high risk, then you can take pre-exposure prophylaxis 0, 7, 21 and 28 days. Okay, fine. So now we are giving immunoglobulins. Immunoglobulins, 2 types of immunoglobulins we have. One is that human immunoglobulins, 20 international units per kg. Equine horse immunoglobulins, we can give 40 international units per kg. Okay. So in the part of what we have seen, a little bit. Okay. In the part of rabies, what is the agent for rabies? Virus. Okay, fine. What is the pathognomonic feature of rabies? Hydrophobia, which is absent in animals. It is present only in humans. What is rabies-free area? Anyone? What is rabies-free? NCT point of view. What is rabies-free area? Rabies-free area means no case for how much time? 2 years. India is for rabies-free area. Usually islands are rabies-free area. What is the islands we have? Lakshadweep, Andaman and Nicobar. They are rabies-free area. Okay. So patient comes with a dog bite. Don't wash for 15 minutes. Running tap water. Bucket ready to the water. Okay. In a one what are not supposed to do? No suture. Okay. Suture to wait for them. Then which day you will provide essence regimen? 0, 3, 7, 14 and 28 days. That is intramuscular. Intradermal regimen? 0, 3, 7 and 28 days. Okay. In the category vaccine matter to bleeding in the category vaccine the immunoglobulin 3 part. Other scenario. What is this? Yes. What is the clue here? Any clue here? Yellow kanna. Say, what is this? Leptospirosis. You have a important clue in there. What is this? What? So the important clue in there. Travel trip to Nigeria. Okay, what is this? This is yellow fever. This is yellow fever. These are the countries where yellow fever is endemic. What are the countries? Central Africa and South American countries. So anybody traveling to these countries, so we have to take yellow fever vaccination. We have to take it. Fine. Key points now. So this is a cycle called yellow fever. What is the agent? Agent and it's flavivirus. It's flavivirus. What is the reservoir? What is the main reservoir here? What is this one? Monkeys. Okay. Agent is virus, flavivirus. Reservoir is monkeys. And what is the vector? What is the vector? In the mosquito. Which mosquito? Come on, focus here. Aedes mosquito. Aedes mosquito. From mosquito, it is transmitted to humans. Okay. What is the incubation period? NCT question. What is the incubation period for yellow? Then it's 3 to 6 days. Okay, 3 to 6 days is the incubation period. From there, it goes another stage. Okay, fine. What is the problem with rabies? What is the problem? What is the problem? Rabies is having how much percent case fatality rate? 100%. What about the case fatality rate of yellow fever? Anyone? Yellow fever case fatality rate is very high. It is 80%. The case fatality rate for yellow fever is 80%. As far as rabies is concerned, it is 100%. Now, either prevent pandemic, what do we have? What do we have is that we need to take what vaccine? 17D vaccines. We need to have 17D vaccines taken. If you take in a designated places, they will provide a certificate. So the certificate validity starts from how many days to how many days? 10 days to lifelong. So if you take yellow fever vaccination certificate and designated place, yellow fever vaccination, they will provide certificate. The validity starts from 10 days to lifelong. So this is one activity we do. Second activity is that we have to make sure that there is no breeding places for Aedes mosquito. Aedes mosquito in the breed for now, sir, where it breeds? Where? It breeds in artificial containers. So we have to make sure that there is no breeding place for Aedes mosquito in and around airports. For how much distance? 400 meters. So you have to make sure that there is no breeding place for Aedes mosquito of 400 meters. So key points. What are the key points here? Yellow fever. First point I'm going to tell you. Yellow fever where it is present? In the countries report out Central Africa, South America. So India yellow fever India. India. Okay, what is the agent? What is the reservoir? Monkeys. What is the vector? What is the incubation period? 3 to 6 days. What is the case fatality rate? 80%. The prevent wrong. 70 vaccine. Okay, I mean here, suppose the question comes. Quarantine panel. The person from South Africa has come to India. So we see on the damage. Lionel Messi has come to India. You are working in the airport development. He has not. Our vaccine certificate. Okay, you are supposed to quarantine. You are not quarantine. We have to do for the maximum longest incubation period. What is the longest incubation period? 6 days. So yellow fever, the quarantine time is 6 days. Next case scenario. So what the end case just be active with me? You learn something. Yes. Enough. What is the clue here? What is the clue? Huh? The left on side of okay. Yes. Some form of encephalitis. Patient is having fever, headache, features are some form of encephalitis is there. What is the another clue? What is the another clue? Pigs are there. Leptospirosis pigs are there. Where is another clue? Rice fields are there. And India now Uttar Pradesh. Okay. So we are going to look in J. This is Japanese encephalitis. Japanese encephalitis again agent is what is the agent? Agent is flavivirus. Okay, it's a type of flavivirus. Fine. Main reservoir birds and pigs. Pigs and birds are main reservoir. What is the vector? Vector in the previous entomology we have. What is vector? Culex. Okay, we have two types of mosquitoes we have. One is Culex trichiniorhynchus, that is a vector in South India, and we have another mosquito is there called as Culex vishnui, that is a vector in North India. That is a vector in North India. What is peculiar about this mosquito? It is in the breed one. Come on, focus here, focus. 20 minutes now. That is what is. 30 whatever breed one. These mosquitoes breed in paddy fields. Okay, rice fields paddy fields. Breed these mosquitoes. So these mosquitoes breed in paddy fields. Chain is common in each area. Rice throwing areas is not common. Not in whole India, it is not common. Only rice throwing areas. This is the life cycle. We have flavivirus, we have birds and pigs, and we have this birds and pigs, we have They are the reservoir. And we have this Culex mosquito. Culex mosquito. Fine. So in the prevent matters, what is the vaccine we are taking? We are giving some vaccine in the national immunization. What vaccine we are taking? Same vaccine, the virus strains. We have a vaccine strain called as SA1442. This is the vaccine strain we are getting. The national immunization schedule. What is the schedule? Schedule number. Schedule. Come on. You don't answer. We are multiple. So we 9 completed months. When is the second one given? 16 to 24 months. Okay, JE vaccine at 9 months and 16 to 24 months we are giving. So to prevent mosquito, we do this integrated vector. So life cycle சொல்லுங்க. What is the agent for JE? Flavivirus. What is the main reservoir? Birds and fish. What is the vector? Humans. Okay. யார் affect பண்ணனும்? Humans. Okay. To prevent that, what we have? What we have is a vaccine. What is the name of this thing? SA1442. Take some images. You find what it is. Just to make the class interesting. Okay. Flavivirus. What means the approach? What is this? Just to make class interesting. Like UG students are prepared this case. Now, discuss we have discussed this term and what it is. Anyone? Yes? It is another. This is Essence. What's the name movie like? This is what? Med. So it is Essence regimen. Okay. Focus. What is it? Quarantine. Quarantine. Okay. Fine. Culex. It is a vector where? Fine, excellent. We'll go to the next scenario. Okay. What is this one? What is this? Delhi village, Himachal Pradesh, some lymph nodes kind of thing. What is this? This is plague, guys. This is bubonic plague. Okay. Now, what is the agent for plague? Agent number? Agent, you know already. What is the agent? Yes. What is the reservoir? Reservoir means where it multiplies. What is the reservoir? Rats. Okay. Usually, these rats needs wild rodents. Usually, wild rodents. And what is the vector? Rat flea. Can anyone tell me what is the name of the flea? That is the vector. Okay. Then it comes to humans. So how many types of plagues are there? 3 types. Bubonic and septicemia. The most common one. Bubonic plague is the most common one. Which is the most dangerous one? Septicemia. Pneumonia is transmitted by aerosol. Okay, that is the most dangerous one. But the most common one is bubonic plague. And to control plague, what do we have? We have to identify cases and we have to treat them with streptomycin. And control of fleas, it is TBT, DXM, control of rodents we have to do. Suppose a big epidemic is happening now. Okay, Chennai, there is a big epidemic is happening. Plague. What do you focus? Control of rodents or control of fleas? Ashwin already goes up to this. What do you focus? Control of rodents or control of fleas? We should focus on control of fleas. Rodents are not going to come and bite us. These are not going to come. Please, okay, then is the play. What is the agent? What is the vector? What is the reservoir? Reservoir. Okay, wild rodents. Okay, what is the vector? Rat fleas. Okay, rat fleas. And the most common one is bubonic plague. Key points that we have to. What is this? Next question. What is this one? Okay, excellent. External part is how many states? What is the flow? How will you do that? Okay, AFD number is the month. So what is the biggest flow is that where it is reported from? Karnataka. Okay, it is reported from Karnataka. And what other clues are there? What other clues are there? Monkeys, dead monkeys. Okay. So we have seen. So this is the life cycle of KFD, Coastal Forest Disease. The agent is again it's a flavivirus, and the main reservoir are rats and squirrels. Rats and squirrels, they are the main reservoir. And monkeys are considered as amplifying hosts. Monkeys are considered as amplifying hosts. Vector, what is the vector? What is the vector? Heart is the vector, and it affects human, especially people living and working in and around the forest. Okay, they are at high risk. So how to control KFD? So you have to identify cases and personal protection measures. From MCQ point of view, if you are seeing hot spots in forest. What is hot spots now? So in the forest, if monkey deaths are there. Monkey deaths in and around monkey deaths in forest is considered as hot spot. 50 meters around monkey deaths. There are very fixed. So during at that time we have to go there. So you have to go and spray this carbonyl propolis spray. This is KFD. So what is the 5 point we learned from KFD? Is the report focus here. Okay, go for one focus. What is the 5 points? In the report from Karnataka is reported. What is the agent? Flavivirus. What is the main reservoir? Rats and squirrels, monkeys are considered as the amplifying host. For J, it is the amplifying host for J. Pigs are the amplifying host. Okay, for J, it is monkeys are the amplifying host. And what is the vector? Hearting. And what is hot spots like this now? 50 meters around monkey legs. Next. Why do we say collards are in a crude media? What is there? What is collards are something in the particular? What is it? Which one? Hyperpigmentation. That is only the important clue. Fever, in the case reported. Case is reported from Bihar. Okay, only in India. 4 states are endemic for collards. What are the 4 states? 9 states are collards are endemic. What are they? Uttar Pradesh. What? Uttar Pradesh. Madam state of Bihar. Jharkhand. What is the next one? West Bengal. These are the 4 states where collards are endemic. What is the reason for collards? East India, broader body. Okay, collards in India happens only in humans. It will not occur in animals. So reservoir area, humans are the reservoir. Okay. What is the vector and the collards? What is the vector? Sandfly. Sandfly is the vector that is phlebotomus. Okay. Main symptom. What is the patient comes with? Any person from these 4 states coming with fever. More than 2 weeks of fever with sphenomegaly, we have to do like collards. In the investigation, all are institutes. What investigations we do? Again, what is the investigation? Government is giving it collards, RK39. The kit is RK39 kit we are having. If anybody is found to be positive with this RK39, we have to treat them with what is the drug? Injection common program free artificial. Liposomal amphotericin. That is the injection we provide. Preventive measures mainly control of reservoir and sandfly control. What is the name of sandfly? Vector-borne. Okay, for sandfly control, we use this indoor residual spray. Indoor residual spray. What is indoor residual spray? Where is it control? It is like very person. But where is it control? For we to pull down the spray on the walls, we do. That is called as indoor residual spray. We will do it for malaria. High risk areas for malaria. J in the heat to pull the mosquito. The mosquito is exotic. We will really get and study. For malaria, so we will spray on the walls. We will spray so that mosquito will sit on the walls. They will absorb the poison and they will take. That is called as indoor residual spray. As the rent conditions used for one is malaria, second one is that is leash maintenance. So what are the key points? Come on, 10 more minutes. What are the key points? In the report, what are the 4 states? What are the 4 states? Okay, Uttar Pradesh, Bihar, Jharkhand, West Bengal. Okay, agent in the Ishmael, Donawai. Yar reservoir, human animals. Okay, what is the vector? Test in the main symptom. What is the key features? We have to look. Fever for more than 2 weeks. Splenomegalia. From these states, we have to rule out Kala. What is the investigation you would like to do? RK39. What is the treatment you are going to do? Report from Conference. Okay, patient is having light colored patches, numbness over these patches. What is this? This is the case of leprosy. Okay. So the agent it is Mycobacterium leprae. The main reservoir, we are going to divide them into multibacterial and quasi-bacterial cases. The main reservoir is multibacterial cases. What is the main mode of transmission? Leprosy is transmitted. How it is transmitted? Yes, main mode. There are others that are the main mode. By droplets. Droplets is the main mode of transmission. So leprosy is one of the diseases India has eliminated. Now tell me here. So every leprosy diagnosed from our program, how we are going to diagnose leprosy? Leprosy is diagnosed clinically. Clinically diagnosed from based on number of patches. Okay, what is possible? What is multiple? How many lesions? 1 to 5 lesions. Less than 5 lesions, we are going to call it as positive. Less than 5 lesions, positive necessary. More 6 or more than 6 lesions, multiple. Okay. Now tell me what is the treatment? Come on. I will ask question individual what you are. Basically question. So yes. That's what we will do. What are the 3 drugs we are giving? What are the 3 drugs? That's one. Entomology. Clofazamine. Which drug is once a month? That's one once a month. Rifampicin is once a month. Okay, first one rifampicin is once a month. That's on 100 milligram daily. Clofazamine for the first dose 300 milligram is once a month and 50 milligram is daily. So 3 drugs to remember. Now the recent guideline they changed this. Okay, fine. How long will you give? What are you going to do? For positive bacillary, you are going to give it for 6 months. For multi-bacillary, how long you are going to provide? 12 months. Positive bacillary 6 months, multi-bacillary 12 months. So we have a program is that National Leprosy Elimination Program. What is this Nicotinamide? Nishshay. NIASHAY. Nishshay. In the disease also, we have an online portal for TB, what is called as Nishshay. Similarly, we have a portal for TB. TB leprosy. Nikos. Okay, Nikos is for condition. Leprosy. Nishshay for Nishshay. Nishshay. It's a home-based pregnancy test. Nishshay. NISCHAY. So we have to create awareness in the program. We have school going girl as a master for leprosy awareness. This is Sapna. Her name is Sapna. She creates it's a character that is used to create awareness. Okay. So leprosy we got, what is the agent here? Microorganism, which you already know. What is the mode of transmission? Droplets. Okay. When do you say it's phosphorus? When do you say it's multivariate? 1 to 5 missions now, positive more than 5 multivariate. What is the treatment they are going to provide? Another one is slopism. How long will you provide? 6 months for possibility, right? 12 months for multivariate. I said leprosy is one of the condition that has been eliminated. What is the criteria for leprosy elimination? What is the criteria? Criteria for leprosy elimination. Less than how many cases? Prevalence of how many cases? Less than 1 case for 10,000 population. The prevalence for leprosy elimination criteria is that less than 1 case for 10,000 population. What is this condition? Last one. I have a question. Which one? Tetanus. Now this will have been prevented. Every prevention. Okay, the daily basis are there. You have a cleaning, the beauty internship. Okay, so patient is coming with injury. You don't know what do you do? Wash the pressing on the child. Wash the money. What do you ask? Okay, when the previous dose has been taken. Less than 5 years, if vaccine has been taken, nothing is required. We are going to classify the wounds as 2 types of wounds. Okay, one is less than 6 hours clean wound and more than 6 hours unclean. Okay, so in both these situations, the patient says that last 5 years I have taken a tetanus shot, nothing is required. 5 to 10 years the vaccine is available, you will give 1 dose for both these situations. More than 10 years, Abhina, so it's more than 6 hours wound, you have to provide what you are supposed to give. Immunoglobulin. Okay, unvaccinated. The patient is in Abhina, you should go for 2 doses. More than 6 hours, you go for immunoglobulin. Okay. So these are the key points. Okay, leprosy we have seen, and this is tetanus. Okay. So in the group of tetanus, last few slides. Patient is coming with an injury. In a case, what will ask? When was the last tetanus shot has been taken? Based on the category, sir. Last 5 years, vaccine has been given. Abhina, nothing will be given. 5 to 10 years. 1 dose. More than 10 years, more than 6 hours old. 1 dose plus immunoglobulin. More than unimmunized, more than 6 hours old. 2 doses will be given and you are going to provide immunoglobulin solution. It's easy question. So fast. What is this one? Newborn. What is this one? RC Respiratory Leprosy. There's some. The term they didn't say this term. You studied micro with that term on this. What is it? Yes, somebody was saying it. Lepromin test. Lepromin test. Okay. Lepromin test. What is the use of lepromin test? These are prepared students. Yes. Lepromin test, key point it is what test? It is not a diagnostic test. What is the use of lepromin test? Is to estimate prognosis. The use of lepromin test is to estimate prognosis. So how will you diagnose leprosy? Now every leprosy diagnosed from clinically. This is ample. This is which is Tala answer. They are using it for Tala answer. 5, 6 MCQs are there. Answer. Yeah, you see cell culture vaccine. Now tell me which regimen. In the regimen, what is the answer? Option, tell me the option. See, there are option in the regimen. Thermal regimen, okay. But how many humans required for this? 0.1 number for one side. Now, I set to go 2 side. 4 days. Someone ever 0.1 number there. Come on, yes. So 5 days, 5 6. In the dogs, then trying for biopsy. Program from the knowledge, okay, so one is. What is the clue here? What is the clue? What is the clue? Unprovoked dog. It's unprovoked, let us assume it's a rabbit dog. Okay, rabbit dog. In the vaccine room, here cell culture vaccine. Okay, whenever we are giving this rabies vaccine to the body, what will you do is that you will observe the animal for 10 days. If animal is healthy after 10 days, what will you do? What is the assumption? Animal is healthy after 10 days. What is the assumption? Animal is healthy. So, you can stop the vaccine. If animal is healthy after 10 days, you can stop the vaccine. Okay, vector control for yellow 400 meters. Okay, next question. What is the vector for yellow? Aedes aegypti. Aedes aegypti. Aedes aegypti ever parakumudi. 400 meters. No. Kami ala empty mare parakumudi. Nanu kike ala 100 meters na ala parakumudi. Okay. False about JEs. False about JE. What is the answer? False about JE. Here. Overhead tanks is not a breeding sex. No? Okay, where the mosquito breeds. It is common in the rice growing areas. The most effective method to break transmission chain in plague. What is this one? Control of bees. Control of bees. What is it? So Bihar suspecting all answer is RK39. So what? Yes. What is the answer? It's a clean node. I had a clean node without any acceleration. 2.0 vaccine is given 10 years ago. What is it? Single dose is required. Single dose is required. Okay. So thank you very much for listening. First of all, I would like to thank Bhavan sir for inviting this section. Thank you all. Thank you.
Thank you for giving your valuable and interactive session, sir. Now, would like to call upon Dr. Prabhakaran, sir.
We got method execution. We hold an MSc campus and statistics and we go on saya orang yang Medical and biological problems. Biostatistics based on data, census method and sampling method, based on data, editing and the classification. Presentation of data, table, graph and diagram. Analysis of data, measurement of sensitivity, measurement of inspection. Last one, interpretation of data, testing hypothesis, not significance. Census method of every element of population investigator. Is the important source of health information, not taking the random, entering the law of Texas, 2021. Census from taking 21 to 71. So, from data, popular, membership, etc. Collection from every number of population, from every number of some number, sampling survey method. Subset of sample. The process called sampling method. Two types of sampling method: property sampling method, non-property sampling method. Sampling method, simulated sampling method, systematic, stratified, structured, multi-set sampling method. Non-property sampling technique, convenient, snowball sampling technique. Every number of population, people start the beginning, select a simple random sampling method, systematic structure, legal or simply designing or check the number. Next, random sampling. Universal from every which relates to the group, every homogeneous population, state of place, the factor, deviation standard, randomly select the initial data. Last one, cluster sampling. Operational homogeneity, cluster or evenly heterogeneous. Equally select for simple random sample, systematic hierarchy, ascending order, and descending order. Equally select the sample, systematic random sample. Next, operation, state of sample, static random sample. Last one, cluster sample, operation, cluster, systematic sample, and cluster sample method. Next, convenient sampling technique. Convenient sample which the investigator is the select the convenient assessment to select the sample. But purpose of judgment sampling, sample selector chooses the part of single degree for the purpose mind. Last one, what are sampling? Sampling technique proportion represent of subject the each program. Next one is sampling technique. The facility for identifying hand-to-hand based on slow sampling technique. The convenient sampling technique and purpose sampling technique, slow sampling technique, sampling technique. Collection of information data, short data, and secondary data. Primary information, primary data, secondary data. Method, observation method, interview method, question method. The primary data is on the right to it. So the information. So the part secondary data. What is public KC, population growth, extension, etc. So the data, explain the hospital part, research lab, silent statistics, demographic data, next one, record, vital statistics, hospital records, not secondary data. Two types of data, knowledge data, knowledge data. Quality data, calculated data, quality data, interval of ratio. Mathematical scaling, mathematical scaling, first of all, category data, nominal and ordinal. In quantity data, continuous and discrete. Nominal data, age center, yes or no, vital status. Next, vital data, cancer status. Annual data, height, weight, PMI. One number, that number of children, number of patients, data. Quantity data, data cannot measure quantity data. An example, colors, weight, beauty, gender, etc. This is sex and etc. are quantity data. Quantity data can be measurable. So, an example, length, height, weight, temperature, etc. are quantity data. Not measurable quantity can be measurable quantity data.
Hang on, one minute. Get that. After that.
Measurement scaling, nominal scale, data they improve quantity can information. For example, male, female, smoker or non-smoker, positive, negative, truth or false, nominal scale. Next, ordinal scale, ordinal classification, nature or order. Any level, stratified levels, ordinal scale. Interval scale, the measurement of scaling equal to the measurement, no absolute zero. For example, normal percent, normal person level, normal 3. Last one, ratio scale, measurement of equal unit of measurement of absolute zero. For example, 48, PMI, HB, RC, Last one, types of table, single, frequency distribution table, opposition table, correlation table, master table. Simple table, frequency table, simple marker, subject mark, frequency table, marker, students. Opposition table, PP, LD. Last one, correlation table, height and weight. Top and diagrams, quantity diagrams, quantity diagram. Quantity, histogram, frequency formula, frequency curve, line chart, frequency, standard diagram, path chart, weight chart, map diagrams. Path chart, histogram, schedule plot, line chart, cost diagram, picture diagrams. So 5 diagrams. First of all, we obtain identify total number. Next, median, arbitrary ascending order or descending order. Last one more, most repeated value, most common value. Second, range difference between lowest value and highest value. Mean deviation, average cases per automatically. Last one, standard deviation. Last is square root of the case in called standard deviation. Top significance. The central spread of area parameter, some equal to some values. Standard error. The standard error of sample distribution is called standard error. Standard error of mean, standard error of proportion, standard error of difference between mean, standard error of mean proportion. Now, standard error is divided by mu, standard error of proportion is divided by n. Mean difference between from standard error of 2 sigma 2 n1 n2. Standard between proportion Q2 divided by N1 N2. Without hypothesis. Without hypothesis, any assumption according to population parameter is called hypothesis. Two types of structure hypothesis. First one, null hypothesis. Second one, alternative hypothesis. Null hypothesis. Hypothesis not difference between null hypothesis. Difference between alternative hypothesis. For example, means percentage among the same group and no difference between false rate. The alternative hypothesis, the mean percentage difference between significant difference between false rate, the alternative hypothesis. So error, rejecting null hypothesis and null hypothesis to resolve type 1 error. Accepting null hypothesis and null hypothesis to resolve type 2 error. Correlation, relation between association or between two quantity measurement of quantitative variable is called correlation. Types of correlation, degrees of correlation, positive correlation, and negative correlation. Number of variables, simple correlation, partial correlation, multiple correlations. Linearity, linear correlation, non-linear correlation.
You are valuable session, sir. Now I would like to call on Dr. Ravi, sir, to felicitate Dr. Epidemiology, sir.
Thanks.
Now I would like to call upon Dr. Gayatri to speak on topic occupational health. Welcome, ma'am.
Light changer. So good evening, everyone. This will be your last session. That's your good news. And the bad news is it will be a complete interactive session. Okay. You people are fatigued and being talking all the time, right? Okay. So we are going to deal with the occupational diseases. Okay. So fourth row, middle one. Yes, you. With specs. You. What is ergonomics? Yes, exactly. Very good. Give a clap for her. So that is ergonomics. Okay. Before that, today we are going to see only the must knows. This is a very important topic and high yielding topic too. Anyhow, from this chapter, you will get at least one question, and for Viva, it will be a short chapter. Okay. So we'll be dealing with the ergonomics and its application, occupational hazards, then classification of occupational diseases, pneumoconiosis, occupational cancer, and two acts, that is ESI and Factory Act, right? So as she rightly told, ergonomics is fitting the job to that person, okay, tailoring to that person. So if it doesn't fit, we have to make changes, both in environment wise and in workplace. Also individually, it should be tailored. So in one of the university questions, they have asked what is ergonomics and how you will apply to it, okay. For that, I'm giving you the example. So if a factory worker, what will be the activity for a factory worker? Obviously, you have to lift heavy weights, okay? And he will stand for a long duration. Also, he will have long duration of working hours. So how we can tailor it? One thing is for long duration, we can put a substitute, and on rotation basis, the worker can work accordingly. That is one thing. And one more, in order to lift the heavy objects, other assisting device can be implemented so that he doesn't have to operate it individually, okay? And the other thing is, we can avoid the bending, frequent bending, by adjusting the working table or working station. So that how we can prevent. So this example you have to quote. You may write any example, but you have to write according to the example. Okay. So what are all the occupational hazards you know? Roll number 65. 65 is in physical, name 3 of them. Yes. Then opposite to heat, cold, then radiation. Okay, sit down. Roll number 72. 72. Present or absent of 72. 75. Yes, in this lecture hall, what is lagging physically? In this lecture hall, physically, what problem do we have? Yes, light, one thing. Light is excess or deficient? Deficient. Because of that, what you will have? If the light is deficient, what problem you will face? Headache, very good. Headache, irritability, and poor vision will also be there. Okay. And obviously, you will get fatigue. And one more thing. Yes, they are prompting the answer. Ventilation. Okay, very good. What is the optimum ventilation one person will need in working place? Anyone else? Volunteers? Yes, sit down. Very good. 500 cubic space per individual. Okay. And here, one more thing we have is noise. So excessive noise will obviously overlap the other person's thing, and you can not able to listen. This is during the lecture hall, but will cause hearing loss. It could be temporary or permanent also. Okay. And apart from that, that will also cause irritation. 110. 110, where are you? Absent. 111. Najman mein absent dana. 111. 109. Yes. Name any chemical agent that is causing hazard. Yes. I didn't get you. Okay, then. Benzene. Abde paathu solringla. Okay. Silicosis is caused by silica dust. Okay, sit down. So, pneumoconiosis is a broader topic that we'll deal in detail in upcoming slide. Apart from that, we have plumbism. It is caused by which metal? Lead. Okay. And benzene will cause what it will cause? Leukemia. And dermatitis, it is usually caused by the direct contact. So in chemical, we have three routes. Okay. One is ingestion, direct contact, and inhalation. Inhalation will acquire the pneumoconiosis, and ingestion, all those metal like lead and zinc, on ingestion, it will cause the toxicity. Whereas direct contact, dermatitis will be caused. Fine, clear with that? And biological agent, not all the biological agent, it could be anything, bacteria, virus, fungi, or parasite. So for example, in bacteria, we have anthrax. Who are very prone for that? Those are dealing with wool. Okay, wool sorters will have that opportunity to get anthrax. And brucellosis is more in particularly which animal? Cow. Unpasteurized milk exposure will cause brucellosis. And leptospirosis, which animal is involved? Rat is involved. So sewage workers are more prone to get that. Fine. Next is psychosocial. So it's dealing with the psychological component. So if a person is employed in a work, one thing he will have is job insecurity, and the shift work will obviously have fatigue in him and any interpersonal relationship issues. Okay. So because of that, obviously he might have burnout syndrome. What is burnout syndrome? Outpouring of emotional disturbance. Okay. And apart from that, depression, anxiety, and stress are common mental problems which will be faced in the workplace. Even students are prone for that, right? Exam stress la irukku. By this month, you should have that exam stress. Yarkla exam stress irukku? எல்லாருமே கூலா தான் இருக்கீங்களா? எப்போ exam? When is your university exam? By which month? Exam stress irundirukkunume. Okay. So mechanical is understood. Any difference in the posture, awkward posture for a longer duration, he will have musculoskeletal disorder. Okay. Can you name any one profession? They are more prone for musculoskeletal disorder. Roll number 84. 84. 85. Quick. 85. Name any one profession which is more prone for musculoskeletal disorder. Louder, louder. Yes. IT professional. IT, yeah? Okay, very good. Sit down. So next is occupational cancer. So yes, no talking, last two rows. Occupational cancer, there are list of different types of cancer. We'll see one by one. So for those individuals who are working in the gas and tar workers, tar you would have seen. Road la podranga in recent times you would have seen more construction works are going. So for that tar workers, they are exposed to the agent called polycyclic hydrocarbon, which is nothing but aromatic amine component. So they are more prone for skin cancer. Okay. Immediately they won't get, only on the longer exposure, they will get that cancerous thing. Okay. And pesticide workers are more in contact with arsenic compound. So they are prone for lung cancer. And those who work in plating industries are prone for nickel component, and they are also prone for lung cancer. And construction workers, they are more prone for asbestosis component. So they will obviously get asbestosis. In asbestosis, which lung cancer is more common? Mesothelioma. What is that? Lung affect pannuma, pleura affect pannuma. Pleura, very good. So for bladder cancer, it is caused by the agent called aromatic amine, which is nothing but benzidine. So all those dye workers and canal workers are exposed to that. And in leukemia, benzol and ionizing radiation. So those who work in ionizing or radiation department, obviously they will be given a period of work-free zone so that they are only limited for that particular radiation. So more than 5 rem is dangerous for them. Okay. And next comes pneumoconiosis. So this thing, what I did is I classified into 2 types, that is inorganic and organic. So roll number 44. What are all the organic diseases in pneumoconiosis? Organic. Slide la ennalla illayo adala organic. Now you can say. Phagocytes, very good. Farmer's lung, one more. That is caused by cotton dust. Yes. Next one. Biostatistics. Yes, sit down. So those are organic things. And inorganic is silicosis, anthracosis, and asbestosis. Okay. So silicosis, obviously, if an individual inhales silica dust, he will acquire silicosis. Before that, pneumoconiosis is inhalation of any dust, particularly which micrometer will affect the lung, from which range to which range. 0.3 to 0.5 to 0.3 microns will affect the lung, whereas anything more than 5 microns will get expelled out. Okay. So in silicosis, silica dust mostly affects the upper part of the lung. Okay. And the complication of the silica dust is it will cause tuberculosis. So which is more similar to the pulmonary tuberculosis. The only difference between silica tuberculosis and pulmonary is the AFP sputum will be positive in pulmonary tuberculosis. It will be absent in silica tuberculosis. That is the only difference. Okay. And on long term, it will cause nodular fibrosis. So on X-ray, you will visualize snowstorm appearance of the lung. Okay. Apart from that, the individual will have usual respiratory symptoms. Okay. And anthracosis is caused in the coal workers. And there are 2 phases in this. One is simple pneumoconiosis followed by progressive massive fibrosis. So simple pneumoconiosis is caused in an individual who is exposed for at least 10 to 12 years in that particular work. He will not get acutely. Okay. And even after that only he will get fibrosis. Fine. Moving to asbestosis. What are all the 2 main components in asbestosis? Amphibole and serpentine. Very good. That is the 2 major component. So the asbestosis, it affects the base of the lung. How you can remember is asbestosis, it has B in it. So it affects the base of the lung. Whereas silica affects upper part of the lung. And here the X-ray finding will be ground glass appearance. Okay. And on sputum examination, you could see the asbestosis bodies. And this will also cause diffuse fibrosis. Here, apart from the routine respiratory symptoms, the individual will also have what is one extra edge here? Pickle varume. What are all those 2C? Clubbing and cyanosis. That will be seen in asbestosis. Okay. So moving to bisonosis. Here, bisonosis is caused by the inhalation of cotton fiber. So clinical scenario pneumoconiosis கேட்கலாம். So for cotton fiber, textile mill worker obviously it is a cotton fiber exposure. Okay. On long term, it will cause COPD like symptoms. COPD like 2 things are there. Yes, general medicine. COPD is emphysema and chronic bronchitis. Okay, fine. So bagosis, it has G in it. So it is caused by sugarcane dust. So bisonosis bagosis kandipa confuse agalam. So you can remember it as G. Word G irunduchuna, it is caused by sugarcane dust. And idukku example eppadi kudukalam appadina, those who work in a paper industry or cardboard industry. Cardboard is formed by the sugarcane residues. So adala or hint, okay? And it is caused by the organism. The organism involved here is Thermactinomyces thackeray, okay? On X-ray, you will have mottling appearance. Coming to the farmer's lung, here the individual will be exposed to the hay or grain dust, and the microorganism involved is Micropolyspora feni. And here the complication is fibrosis and cor pulmonale. What is cor pulmonale? Pulmonary hypertension is caused due to failure of right ventricle. Okay. So coming to the preventive measures. So preventive measure, what are all the three types? Roll number 58. 58. Yes, what are all the three things in preventive measure? Louder, louder. Medical measure. Okay, I'll say I'm not audible. Primary, secondary prevention won't come here. And one more thing, yes, sit down. And one more thing I wanted to say, prevention, any question ketalo, you're writing primordial, primary, secondary, tertiary. That doesn't apply in everything. Okay. Here, preventive measure ne ketangana, stick on to this. So there are three methods. One is medical, engineering method, and legislation. Okay. So in medically, what all things to be followed for a worker is, that is a industry worker is. So initially, pre-placement examination will be done. So before he is appointed, he is getting appointed to that factory or industry, he will be examined thoroughly. Okay. In all components, say physically, mentally, and socially, he will examine. So for examination, usually what all we'll do? Blood investigation, urine sample investigation, all that he will undergo, ECG, X-ray, everything will be taken, and only then he will be chosen for that job. Okay. And after that, only pre-placement examination will not be enough, and even periodical examination is needed. So after specific time period, say certain jobs will require every month examination also, and in certain industries, they will do 6 months once or yearly once examination, irrespective of the complaint he or she has. Okay. And even before the appointment, even before he is getting appointed, he will have a health education and health training oriented to that. So if he or she is using PPE, what is PPE? Personal protection equipment. So he will be learned on how PPE usage is being done and what is the use of that and what are all the things he is getting exposed to and what are all the rules he has to be followed. So even before the appointment, he will get this. Okay. And then early diagnosis and treatment. So there will be in most of the industries or companies, they will have a medical officer there. So they will have frequent examination of that employee. Okay. So that we can have early diagnosis and treatment. And next is immunization. For example, if they are working in, for example, say cluster kitchen, what vaccination should be given for that individual? Roll number 32. If a person is working in a cluster kitchen, what immunization he or she has to do before entering the job? Hepatitis is the clue. Ava, B, C, D. Yes. B for health workers. Those who deal with food and food handling should be immunized with hepatitis A, rightly said. Yes, sit down. Okay, health workers, Adamari, should be immunized with hepatitis B. I'm sure all of you got immunized with hepatitis B vaccine during the first year itself. Why? Because you'll be seeing patients frequently. It is just a precaution. And then maintenance of health records. So right from the start, the individual's health record will be maintained for further future references also. Okay. And rehabilitation. So what are all the types of rehabilitation, you know? Yes. Medical, vocational, and rehabilitation types. Tertiary prevention, haven't you read? So medical rehabilitation is there, where physiotherapy will be dealt with, and vocational is training a person for a job opportunity, okay, and social rehabilitation. Fine. And then comes notification. So what are all the notification disease in pneumoconiosis? Roll number 16. Roll number 16. Get up. 16. 1 6. 17. Yes, what are all the notifiable disease? Yes, any volunteer who know the answer? Silicosis, anthracosis, asbestosis, அது இல்லாம இல்ல அவ்வளவுதான். In pneumoconiosis, only 3 things. Apart from that, we have occupational cancer also. Okay. So these are all the notifiable disease. Fine. So this is in medical measure. Moving on to engineering measure. So here, substitution is if there is any harmful substance that should be substituted with less harmful or no harm substance. Okay. For example, lead can be substituted with nitrate. Okay. And zinc. And isolation is isolating a particular hazardous thing in one building so that the person is not getting in contact with that. Okay. For example, if it is a hazardous procedure, they will ride it over the night so that the person will not be in contact with that. Then comes ventilation. So what is the adequate ventilation for one person in workspace? I just told 500 cubic meter. So that should be maintained. That will be assured there. And dust suppression is done by drilling the rock with the water or spray method. So usually mop pannale dust varadu. So that is the basic thing. Okay. And good housekeeping. So first employee ponone cleanliness irunda pattadu. It should be throughout the thing. So routine cleanliness is maintained only by good housekeeping. Fine. And workplace design. So while establishing the workplace itself, the proper blueprint should be planned accordingly. So such that the building gets adequate ventilation, adequate air, and it is away from the residential place. And the workplace should be surrounded with the full green belt area. Why? So that the air exchange will take place and less harmful substance will get into the residential place. Okay. And PPE provision is, what is PPE? You told right now. Okay. So roll number 62. Name the PPE. What all things will come under PPE? Yes. PPE la enna varum? Gloves. Very good. Louder, louder. Okay, then. Respiratory related, which is more important? Mask, respirator is very important. Yes, sit down. So those PPE will be provided and they'll be learned like how to use that. Okay. So coming on to legislation, there are two legislation. One is Factory Act and the other one is ESI. Okay, this is very important and most repeated question. Either way, you will get either theory or in practical Viva session, you will get it. Okay. So in Factories Act, so who are eligible for this is if a factory has more than 10 workers with power or more than 20 workers without the power involvement. Okay. So the health regarding is just now we saw it should be clean and proper ventilation, lighting, and there should be a provision for safe drinking water. Also, there should be latrine, adequate latrines and proper disposal of waste that is generated. Okay. So for safety purposes, so beside the mission in motion, they have to mention the precautions. Okay. You would have seen that warning signals also. So that is mandatory. And proper emergency exits should be established in case of any emergency situations. And along with it, fire extinguishers should also be present. These are all mandatory norms. And the industry should also ensure welfare of the person. So if there are more than 250 workers in that particular workplace, yes, no talking last rows. In the workplace, if there is more than 250 workers, the canteen should be established. And if there are more than 150 individual, proper shelter should be there. And if the particularly women is more than 30 in number, crutches should be present. Okay. And welfare officer should be there if there are more than 1,000 individuals. Fine. So what is the allowable working hours? Roll number 8. 8. What is the allowable working hour? 8 hours. 9 hours per day. That is on the whole at least 48 hours per week. Okay. So the rest interval will be like after the 5.5 hours, there will be enough break. And after that, the rest of the schedule will be continued. If the individual is young, the interval will be after 4.5 hours. Okay. And no child less than 15 years should be employed in a work. If the child is between 15 to 18, what I told now is the break will be given half an hour before. Okay. And along with that, if the employer works continuously for 1 year, he or she can claim 20 days once leave can be claimed by them. Okay. For adult, and for children, 15 days once he or she will have a allowed leave. Okay. And for that, they will have a paid wages. And then comes ESI. So ESI will deal with the social security. So it's nothing but a insurance scheme. So which will be contributed by the employer and the employee. Okay. Whereas in a Factory Act, we only saw the norms that are to be set and followed in that particular workplace, and ESI is the insurance. Okay. So here, this is not only for the factories, but also for the shops, hotel, restaurant, cinema, theaters, and educational institute and other private institutes as well. Okay. So who are all eligible is who all gets the wages of at least rupees 21,000 per month. And for disability persons, at least 25,000 per month. And here the employer will contribute 4% of his wages as an insurance, whereas the employee will contribute 0.75. Yes, Hariharan, don't talk. One more slide is there. So what are all the medical benefits you are getting out of that? Yes, roll number 34. 34. What are all the medical benefits? They are getting paid for the insurance. Insurance koduthaangana enna benefits medically? Individual ku mattum dana illa family ku serthu iruka benefit? So the benefit is both for the individual and the family. So medically, he or she can have a free OPD services. Have you heard of ESI hospital? So that thing is there. And apart from that, certain private institutes are there where ESI isn't tie-up. Only then they can claim. Okay. So for sickness, sit down, sit down. So for usual sickness, if he or she is in a sick leave, they will get paid for the 70% of the wages for a maximum of up to 91 days, provided they should have contributed for at least 78 days prior to this. Okay. And then comes extended sickness for certain chronic illness like TB, leprosy. So we do have 34 specific diseases. If the individual falls under this category, they can extend their sickness for up to 2 years, and they will get 80% of their daily wages. Okay. And enhanced sicknesses, full wages will be given for those who undergo vasectomy. They'll get a full wages up to 7 days. And for pubectomy, they'll get 14 days of full wages. Coming to maternity, so now they have increased up to 26 weeks. So here 8 weeks can be claimed before the delivery, whereas the remaining should be claimed after the delivery, that is postpartum period. 6 weeks in case of any miscarriage or any abortion has occurred, and 4 weeks in case of any complication that has arisen out of pregnancy or postpartum period. Fine. So moving to if the individual is disabled temporarily or permanently, 90% of the wage will be given in case of temporary, whereas if he or she is permanently disabled due to the employment related injury, they'll be given 90% of the wage throughout the life. Okay? And dependence benefit is in case of any death faced by the individual due to the employment related injury, they will be given 90% of the wages to the dependent child. It could be son or daughter for up to 18 years. If the daughter is married before the 18 years, that can be claimed. Okay. Then comes funeral expense. Here maximum up to rupees 15,000 will be given. Fine. So that's it. We are ending. So any questions? No questions? Roll number 54. 61. Okay. So ESI benefits la name any 4 benefits. Name mattu sonna podum. Maternity benefit, then medical, sickness. One more. Very good. So give a clap. Thank you.
Thank you, ma'am, for giving your valuable interactive session.
Shall we start the next session? One more topic. So how was the day? You people enjoy or? Okay. So we'll start tomorrow's session by 8:30. Okay. Try to come fast. So tomorrow we have exciting sessions, community medicine as well as FM, and we have peace program also. We have the grand peace program is there in the afternoon. Everyone should attend. Okay, everyone should attend. 3 prizes will be given. First prize, ₹1,000 plus certificate. Second prize, 500. Third prize, 250. Same way, essay competition results and short notes competition also will be announced tomorrow. So, anything else to convey them? Yeah. So tomorrow we'll take 2 attendance, 11:30 and 2:30. 2 attendance will be taken for the documentation purpose. So we are happy to announce that Tamil Nadu MGR Medical University has given 20 credit points for this program. So we'll be given the certificate mentioned those points tomorrow. So thanks everyone for conducting this program without any hiccups. So we'll meet tomorrow, the same time, 8:30. Okay. Bye-bye.
Screen might be there. You can see here also. There also. இல்ல அதுதான் ஆபரேஷன் இது only
So good morning. Can you have your attention, please? So I can understand it's really painful situation for you to listen communities for past 3 days. Yes, even I concept. Yes, yes, no. Yes, okay. So then we don't like the go like a lecture. Can we have an interaction? Can I come along? No? Yes? Yes, no? Yes. Thank you. So, okay, giving me information before. So, before I go into this session, so I would like to thank the organizing team, and a special thanks to Dr. Prabhakar and Dr. Jeffel for inviting me to give a discussion. So, here I have shown a picture. So, my problem is pointer is not there in space. So I don't know, I can't point it out. So you can see like one scenario I have given. There are 200 people that are suddenly fall sick with vomiting and diarrhea. So what is it? What do you think about it? Somebody suffering from diarrhea. Suddenly 200 people are infected with diarrhea. What do you think about it? You need mind? Something has happened in that city? Yes, what is it? Please follow up. Something has happened. So, have you heard about like endemic, epidemic, pandemic, one more component? Outbreak. Have you heard about outbreaks? Yes. Silent outbreak. Have you heard of outbreaks? Please you be attending now. So what is an outbreak? When you call a condition like this happen on you? Yes. So we call an outbreak. See, you know what is endemic, right? Yes, you know what is endemic? So in a hostel, every month this many cases of diarrhea suffering. Say for example, 10 cases of diarrhea suffering in your hostel. Then you say that it is an endemic. I'm taking a small group, okay? And if suddenly 200 students are affected in that place, what do you call that? It's an outbreak. Okay, some outbreak has happened in that space. So it's going to include the wide area. Then you call it as epidemic. And if it is going to cross the international borders and include everywhere, then you call it as pandemic. So all these things are affected. What are we supposed to do as a medical officer? So I'm a medical officer. So I know that in this hostel, this outbreak has happened, this city outbreak has happened. What steps I have to take? So what I will do? So whenever you put all WSTs, why, not, when, how, all these questions you're going to put, you will get some answer. Yes. So what is this? What is this? Yes, it's a SWOT map. So with that, what they have done? With that, what they have done? They have seen the research. They have seen the basis where the cases has been reported as cholera. Yes, they spotted everything and they found out that this is the handbook which is responsible for causing cholera. And based on that, they started making modifications. You're clear? So what topic it might be? What topic it might be? I'm studying about the cells. I want to know where the receptor, when the receptor, in detail about that. And I spot it, and then I come to a diagnosis. Based on that diagnosis, I'm going to apply the preventive measures and control measures. What can it be? Chapter it can be. So it's a topic of epidemiology. Yes, right? So So the topic is epidemiology. I explained. I'm not going to touch in detail about everything. So most important points as an undergraduate student, what it happened, only that I will explain. Okay. So in this PowerPoint, you can get it down first. I have given the important questions at the end. So they said it is must to give a pre-test and post-test questions. So I have put this. So you have heard about the study designs. Please read this questions. I will give you 1 or 2 minutes time. Read this and write your answers again. Okay? Yes, 2 minutes time. So and then I'll ask somebody to help after post-test. As you can read, you can apply, you can see which option will be. 2 minutes. ABC. Yes. You want me to read? So you are having the options with you. 1, 2, 3, 4. What is ABC? I'm going to say these answers. I'll give my whatever they give to me. I'll give it. Yes. Yes. You proceed. So we are not updated with the technology. Okay. I'll go 3 questions. The main purpose of explaining text is to please don't say answers. Okay. Next is red blood glucose monitor gives almost same readings every time you check patient sugar. But the readings are consistently higher than the true values. This test is following options. Yes. Next is identify the screening program in India. Yes. Then, so we will go with the topic. At last, if you are going to answer all 7 questions, I feel like my class was affected. You are not able to, then it is my fault, not your fault. Specific learning objectives for epidemiology as we are not going to go in depth about it. So, what is epidemiology? So, what do you understand by the term epidemiology? So, few things are there. What you are going to study? You are going to study the distribution and determinants of an event or a specified states or events in a specified population, and they gain the knowledge, apply the knowledge to prevent and control the disease. Got something? So, some events is going to observe. So, what you are going to do? How it is distributed? Then, what are the determinants or determinants are called as risk factors? So, what are the determinants to cause that disease or that event? So, you are going to find out. If you gain knowledge and apply that knowledge to prevent and control that event, that is called as an epidemiology. So here, so already you have seen what you are going to do. distribution factors. What are they? How it is distributed. When any disease is there, how it is distributed. So time, place, and person distribution I am going to tell. What are the determinant factors? What are the risk factors? Is it the age? Is it the gender? Is it the socioeconomic status? What are the risk factors I'm going to find out? And based on that, I apply the epidemiological study design and I formulate an hypothesis or I test an hypothesis. Either I formulate an hypothesis or I test an hypothesis and apply the preventive and control measures. This is what is about epidemiology. What I will do if there is an outbreak or whatever incident which happens. So how am I going to do it? So ask questions, make comparisons. With the two approaches, any event it occurs, we have to do. Ask questions. What are the questions? Already I said. All the W questions you can apply. We are going to do so. You will get a picture of what is occurring. Okay. So say what, where, when, why. So if this questions are answered, then you get a descriptive study. It is always called as descriptive epidemiology. So if you are going to answer why and how, then you get a analytical epidemiology. Like what are the studies of analytical epidemiology? Case control and cohort study. So these questions, when it is answered, you get the information about it. Okay. So what is epidemiology? This is what you'll be doing in epidemiology. So first is studying the distribution of disease with reference to time, place, and person. That is called as descriptive. So when you are going to assess the etiological or the risk factor, you are going to find out this is the risk factor. Then, if it is prospective or it is retrospective, that type of epidemiology is called as analytical. Then, recommending the prevention, see, in definition, everything is there. So, if you are going to recommend the prevention and control measures, how do you do that? You do epidemiological investigation and you apply the preventive measures and the control measures. Then it is called as applied epidemiology. So I am going to test for COVID. What has happened? COVID. What are the type of different types of COVID vaccine? You know. So I have intervened something to stop that disease. Am I right? Yes, I did that. 2019 when COVID vaccine was there. No. So I have invented something new. So I have given that new everyone in the population. Try to stop it. So if you are going to do some intervention, then it was called as experimental epidemiology or interventional study. So now I feel that we have an idea of what is epidemiology. So how we are going to measure? Always there is a confusion between rate, ratio, and proportion. Do you have confusion? Are you confused with rate, ratio, and proportion? If you are going to interact and with the analysis, we going for me. Don't have any confusion? Second yes, right? Yes. You have any confusion with this? Rate, ratio, and proportion? Yes, sir. Yes, sir. Yes. We have an answer. Okay. So what is it? What is rate? So you can apply this answer. This numerator is a component of denominator. Okay. This numerator is a component of denominator. If you are getting the answer of no, then it is called as ratio. Okay. What is that? P divided by B. Is there a numerator component of denominator? No. That is not. It's not. This one is ratio. If yes, again you apply one more question. Whether time included in that, whether time is included in the denominator. If it's no, then it is a proportion. If it is yes, then it is called as rate. You are clear about it? Yes. Okay, some examples here. So for rate, measures the occurrence of demand in a population over a period of time. And component is rate. So infant mortality rate. I have given one example. Ratio, there is no relation between the numerator and the denominator. So it is ratio. Okay. Proportion, what is it? The type of ratio where the numerator is part of the denominator. So out of this 150 students, how many are listening to my class? Yes. So how many what proportion? I can take 5%, 10%. What percentage are listening? Okay, I'll put it like to my satisfaction. So some 80% are listening to my class. I keep it with them so that I will get satisfied. Okay. So that is solved as proportion. So to just to remember for you, ratio is time, ratio is comparison between two components, and proportion is part of the whole part will be there, that the numerator will be a part. Okay. So static is everybody knows about static is. What is it? Already I said. But how it is broadly divided? Observational and experimental. Under observational, descriptive, analytical. Very good. Under descriptive, based on what you study, time, place, and person. With descriptive, what you do? You form a little bit hypothesis. I would say this is the reason for this disease. Only that I can say. With analytical, how it is classified? Case control and cohort study. With that, what you do, you test the hypothesis. So whatever has been claimed, you test the hypothesis with the case control and cohort study. Yes. And one more is what is that? Experimental study. Under that, what you know? Randomized control trial, clinical trial, community trial, field trial, all types of trials and all types of trials will be there in the experimental study. Okay. So what you need to remember? Descriptive study, you hypothesis formulation alone will be there. If it is analytical, you will be testing the hypothesis. And in the experimental study, you will confirm that this is the result of this. You can confirm the hypothesis. Okay? Yes. Yes. So this is the wide thing about the study designs. So on the observational study, we just repeat interview inventory. It's natural course. So without intervention, something is happening, then it is called as observational studies. Already you know, this descriptive and analytical. In descriptive, it is just you tell what this is prevalent in this area for our population. So you don't say I'm going to carry a writer. Everybody, we are having that. So every time in my hand, a cigarette title is there. What you would think? Small. You have, I don't know, maybe my husband will always ask me to carry it. So I'm carrying it. But when I realize how it will be, so this person is carrying the lighter. So there is some association. Okay, she will be smoking. Yes, you will tell me or not. Yes. But it is not so. I don't smoke till now. Okay? So that is what is called as something. Begin to be. So analytical is what? Analytical, you test the hypothesis. Okay, you go back behind madam and observe what she's doing with that writer. Whether she's smoking or not. I will send to the friends and then my other friends. So whether she's smoking or not. I will be testing. So then it will come under analytical. Okay. So next is, so you are going to see the determinant, exclusion, and the behavior. You are going to intervene. So you will come and say, no, this is not implant, don't have the vector, don't smoke, please, you will get lung cancer. So I am going to stop it because some students say, please, I am not doing, you don't do it. So some intervention is there. So if I am going to give that intervention, then it is called as experimental study. So you here, I hope so. So descriptive study, already I said what is descriptive study? You are going to describe the occurrence in terms of time, place, and person. So these are the differences. You can go back and see and taking detail about it. So time, place, and person distribution, we are going to study about any occurrence, any event which is occurring. So most important, what we do? We formulate a hypothesis in a descriptive study. Here what we have formulated, they wanted to see the association between smoking and lung cancer. This is given in your part. What has been formed? they are saying that smoking 30 to 40 cigarettes per day causes lung cancer in 10% of the smokers after 20 years. Okay, this is the what they have claimed after doing the respiratory study. So that you don't say, okay, in 20 years after that only, I'll get the lung cancer. No, it is okay, I can smoke. It's not like that, boys. Okay, girls also starting. They are saying like that, telling you, no, not only us, they are also smoking. So, peace. Okay. Next is the prevalence of hypertension varies with the level of physical activity among adults in the study population. Okay, you do physical activity? Yes. I do physical activity. So I'm just having only exercise, not diabetes. Okay. So if you start doing the physical activity, is there a change which occurs? Yes or no? Yes, the change occurs. Okay, this is what this history, the formulation of that hypothesis. So next we do case control. What is case control study? It is otherwise called as a retrospective study. Case, you remember at least, so whenever applying questions are asked. So the first question will be find out what type of Epidemiology study it is. So if you are going to write a wrong answer for case control part, then the whole answer will be. So you can't fetch marks. So you please remember, case is given the case control study. Only one thing to remember, format study automatically will be remembered. So case control study, if the case is given, already the case has occurred, already the outcome has occurred. From that, you go back and find out what is the reason for the occurrence of this disease. Okay. For lung cancer has occurred, you go back and find out what is the risk factor for occurrence of lung cancer. This is a retrospective study. Called as retrospective study. It goes behind. Okay. Yes, you're clear? So it's a retrospective study. Usually you will be having a control form. So cases will be the individuals who are with the disease. Clear? Cases will be the individuals with the disease, controls without the disease. Okay. And then they will be finding out what past exposure they have. So this is what is called as case control study. This is the flow. So you take a population and you see the cases with the disease, controls without disease. You proceed behind. So you can see the direction of endpoint from now to back. So it is called as retrospective study. And we see whether the exposure is present or in the cases, how many are smoking, how many are not smoking. In the controls, how many are smoking, how many are not smoking. So you do that and you analyze. What is the analysis for case control study? Yes, so don't remember some case. Yeah. So these are some of the steps, but I don't want to go into the steps. I'll be telling you why, what is the importance of matching alone. Okay. What is matching? Why we keep matching? Matching alone. Why the cases and controls should be matched? Can the cases be the individuals who are 80 and above and controls be the less than 5 years? Yes. Can I compare them? Okay. Then I can conclude that this whoever is more than 80 are developing cancer and the other is developing cancer. Can I compare that? It's not possible. So it has to be matched. At least something, whatever exposure you are going to study, for that alone you are not sufficient match. For all other things maximum you have to match. This age group and that age group should be more than 20 to 40. Controls also should be 20 to 40. Okay. So I'm taking upper socioeconomic status for you. To take, so I'm going to study about the stress. Okay, stress levels. So here I am taking upper and there I will take lower socioeconomic. It will be comparable. I can't compare this. So both should be in upper socioeconomic status. So that I can see the stress level. We are working in making how the stress level is like accordingly. Okay, yes. So the most important is what happens? You need to know about the confounder. So if you are not going to match, so the confounding effect will be there. So whatever this I'm studying about smoking is, might be that only will not be the cause for recurrence of lung cancer. Okay, got it. There will be something else also. The person is taking something else. Okay, working in asbestos industry, and he also smokes. But I'm not going to control about asbestos. Then indirectly that can also cause cancer. So I don't know the pure effect of the smoking. So that is called as a here they have given this is a common example usually they give. That's coffee drinking causes lung cancer. Coffee drinking. You can see outside persons who are going out. They'll be having coffee. Coffee drinking causes lung cancer. What might be the confounder there? Needles. Coffee is not a there is not smoking. That is not the reason for lung cancer. So in that some confounder which I have not controlled is also there, which can cause lung cancer. So how are we going to control this confounding effect? So these are some of the ways, this is for postgraduates, not for undergraduates, how you can control the confounding effect. So at design stage, so what you can do, you can do matching, restriction, randomization. These things if you do, control the effect will be less. And the analysis, it is stratification, statistical multivariate analysis, and standardization. So it is like your entrance question. So if you do these things, compounding effect can be controlled. So what is the analysis you do? Odds ratio. Just like that, you remember it is a cross product ratio. So activity one. So 5 minutes you take. The formula is given A, B, C. Here I have given lung cancer, no lung cancer. Can you find out odds ratio? Simple calculation. No. Can you find out? Yeah. Oh, yes, very good. That means what? That means odds ratio says this many times they are at risk to develop lung cancer when compared to normal individuals who are not smoking. Yes, you got it? The persons who are smoking or this many times, how many times? 4 times it is to develop lung cancer when compared to the individuals who are not smoking. That is what your report is. Odds ratio is 4. So, and then you need that. So, odds ratio is 1. Same, there is no association. If it is more than 1, some association is there with smoking and lung cancer. If odds ratio is less, then you say this protective. Okay, yes, you got it. So what is descriptive study? What is case control study? You got it. I hope so. So these are some of the other case studies which has been done already. And 1 merit and 1 demerit. For case control, you remember, it is suitable for rare diseases. Okay, so you can't take the rare disease and you do a cohort study, follow the study. So it takes years together to develop this. So rare diseases, chemicals to rare diseases which you have not heard about. Sickle cell anemia, I have not seen. Some rare diseases I take and I go back and study. So 1 merit is rare disease. 1 demerit is not able to calculate incidence in case study. This is your MCQ question. Just a So this is a cohort study. What is cohort? So you take a group of individuals who are exposed to the risk factor. So you know what? Case control is you take the cases. Cohort study, you take the individuals who are exposed to the risk factor. So cases and controls. Controls without risk factors. Okay. And then both the groups are combined. So you can see here, the cohort is healthy subjects. exposed subjects, the persons who are smoking and the persons who are not smoking. So I'm going to follow the forward-looking study. It's a prospective study. I'm going to follow everything. So like I'm taking my writer, one student is observing me for years, student is going to follow me. Whether the madam is getting lung cancer or he's going to follow and see. So that type of study is called as forward study. We are going to go forward. This forward-looking study. There are different types of forward studies. One is prospective, retrospective, and ambidextrous. So I put it in simple words. Prospective is from this factor, you go forward till they develop the disease. That is called as prospective. Next is retrospective. Why it is called as retrospective also? What they do? The case of lung cancer occurred, or maybe lung cancer is access to history. So they go back, it's 10 to 15 years behind, and see, come forward, they will check how many years he has worked with massive history. Like that, they'll be coming forward, and they will start following for them. That is called as retrospective. No, it's not names. So that is called as retrospective, and the sectors they follow them. So diabetes, they go back, follow them forward, and again they look for the complications. That is called as an epidemiology. So this is what it is. So from exposure to outcome, that is called as prospective. So they go back and come to the outcome, that is called as retrospective forward study. And after coming to the outcome, if they are going to follow them out again, and it is called as ambidextrous. Okay. So what are three things you calculate? It's taking which is not simple. So analysis, you remember add. What I calculate? Add. Honest, attributable risk, incidence, and related risk. So in case of forward study, what I calculate, analysis will be add. Okay, attributable risk I calculate, incidence I calculate, and related risk I calculate. So the most important related risk is similar to odds ratio. Okay, more or less. So what it says, how many times they are at risk to develop that disease. That is what related risk is. Okay. Attributable risk is how they could have been prevented that disease. What percentage of the risk is the reason for the occurrence of that disease. That is what the attributable risk. Incidence. Yes, incidence prevalence. Incidence is new cases, prevalence is both new and old cases. So remember, incidence, new cases, related risk, how many times higher, how many times they are at risk. Attributable risk, how much extra due to exposure. Okay. This exposure, they will not prevented, they will not develop lung cancer. So this is a problem. So the answers are given at the end. You can get the PPT and put it out. So next is what the relative risk is. The larger the relative risk, the greater the strength of association between the suspected cause and factor. Already you know, right? If I am saying relative risk of 7, so it shows that the strength of association. This smoking is causing lung cancer. 7 times higher of this cancer occurs, lung cancer occurs due to smoking. That is what relative risk is. What attributable risk is? It relates to what extent the disease understanding can be attributed. It will give the percentage. I will say 20% is the reason for occurrence of lung cancer. It is attributable. So what use you can calculate and attributable distance relative risk. 1 minute temporal relationship you can find out. Okay. What is temporal relationship? Always the risk factor will be before the occurrence of the disease. That is temporal relationship, which you can upload using cohort study. It is inefficient for analysis. 1 minute and 3 minutes. The next is experimental study. So you'll be knowing about experimental study.
So sample population, you take study population and you allocate random is done and allocate into cases and control. So what do you mean by randomization? It is similar to matching. Okay. So one important point you have to remember, what is the gold standard epidemiological study designers? RC. This is a gold standard design. Okay. I don't want to go into that. What is randomization? What do you mean by randomization? What do you mean by randomization? Assigning the study participant in both groups, intervention and non-intervention groups. Okay. So by using this method is called as randomization. This is basically done so that both the sides will be compared. Already I said. So we can reduce the confidence. Then you can say this is the result. Going to test some drug, then I can say this is the drug which has reduced the inflammation. Okay, so for that, confidence should not be done. So there are different types of randomization: simple, block randomization, stratified, and cluster randomization. Simple is you by chance you pick it or you toss a coin. This person should go to this group or that group. Okay. So block randomization, we block it 6, 6, 6, 6 like that. You divide them. Stratified is like age 20 to 30, 30 to 40, 40 to 50, and to style. That is called as stratified. Cluster is you take that cohort, the group of individuals. Okay, who are studying in first year MBBS, second year MBBS, you can take like that. Then this called cluster. So you can remember simple, toss, coin, block, equal number per block, stratified, balance, important factors, and cluster is whole group balance. So now we can answer. Indeed, 10 countries are analyzed for association. Is it a cohort study? Is it a cohort study? Please read again. Data on per capita sugar consumption and various prevalence from 10 countries. I am going to compare the countries. Is it a cohort study? No. Is it a case control study? Yes. No. Is it a randomized? And intervention is done, and intervention is done? Yes. Yes or no? No. Then what it is? Ecology. So when you take the group of population and if you're going to compare, then it is called as ecological study. Remember. So these things I have not said for one time survey. So whenever you do an MCQ, you have to do. So you know three things. You know case control, cohort, and randomized. You know cross-sectional study. That's a one-time test survey is conducted in ST, measures the prevalence of hypertension in association with solid intake. What type of study it is? Cross-sectional. Why? So I give a performer note to everyone. I will ask the history of salt intake and about your weekly administration. And this one a snapshot. Standard and survey the performer. And then I'll take the performer. Then one time if you're going to do it, it is called as cross-sectional study. Okay. So you read it properly and understand. In hospital, patients with myocardial infarctions are compared to patients without myocardial infarction. What is found? consistent, possible, and shows dose response. So if I smoke 10 cigarettes, I will develop lung cancer after 30 years. If I smoke 50 cigarettes per day, I develop lung cancer within 5 to 10 years. So dose response. So you are going to find out whether it's association or causation. Yes. You want to know your clear what is association and what is causation? Yes. Great. So next is screening. What do you mean by screening? Whenever I talk about screening, what we remember? We remember about some short answers. Iceberg phenomenon. You remember about iceberg phenomenon? What is it? The tip of the iceberg is what? There is deficiencies. The submerged portion is what? The precision vessels. What are you going to do? How are we going to find out? Then where the screening vessel. So can you give some example what this is? Screening procedure, hypertension. So I'll do BP measurement. Fasting blood sugar can be done for diabetes after 40 years. So I want to find out whether they are pre-diabetic or diabetic. Can be done. Any other? Breast cancer. What screening tests will be done? Mammogram, cervical cancer. These are some of the conditions what we can do already discussed. Tuberculosis, sputum examination. So these are some of the screening programs, national programs which you say. What is there here? One is for non-communicable tuberculosis. One is for anemia, where the school health program is done. Next is tuberculosis program. So this is the difference. What is the difference? Screening, but you don't know about this. I'm not going in depth. Only what is reliability and what is validity. So what is reliability? The ability of the test to give same results on reputation under the same condition. So if I ask some 10 students to come and check my BP, how it has to be? If say until unless I got stressed and calm and still here, then maybe 2 million or 3 million or 5 million very little. But it will be more or less the same. Right? Yes. So that is what is reliable and consistent. What is validity? The ability of the test to guarantee the accurately measure what it is supposed to measure. So that is called as validity. So it close to true values. It should be very close to true values. So that is what the importance of screening. Okay, so if I'm going to use some screening test, it should be reliable as well as it should be valid. So I'm given different pictures. So center is the true value. Now you are going to tell me whether the first picture, what is it reliable? You can see. It's reliable? Yes, it is reliable. Is it valid? No, it's not valid. Yes, reliable, not valid. Next is not reliable, not valid. Why not? I can put it closer to the true value. Yes, not reliable but valid. Okay, next is it's not reliable, not valid. Next, reliable and valid. Okay, so this is what you need to know in the screening. Now you know. Already we have worked out. Yes. Already all cases we have seen here. Discussed. Post test. How many got correct at the end? We have given some 6-7 questions. The main purpose of screening test is to come out to you do screening test. Huh? Chance. B. Right. Next. You would have understood label and valid, you would be answering this. Label but not valid. Yes, very good. 7 out of 7. Everybody, what is the program? Anemia molecular. Yes, very good. Any questions? It's very difficult to cover epidemiology screening in one class, but still, most important points I hope I can cover. You know the statistics, you know association and causation, you know what is the basics in screening, what is validity, what is the yes? Morning. Evening. Thank you. These are the some of the references. Thank you.
I would like to extend our heartfelt thanks, Dr. Vedapriya ma'am, for taking time to be with us today and for sharing such a valuable interactive session. Thank you, ma'am. Now, I would like to call upon Dr. Prabhakaran sir to felicitate Dr. Vedapriya ma'am.
For the right answer, 1%. 7 out of 7.
I would like Dr. Prabhakaran sir to felicitate.
7 out of 7. MCQ. Please somebody raise. No? Nobody got. Yes, come here. Who's that person? Got 7 out of 7. Speech is allowed. Speech is allowed. You can't teach it. You can't. No teaching.
Dr. Prabhakaran sir to felicitate Dr. For the next section, it's the lead pleasure I invite Dr. Prabhakaran sir. Over 30 years of experience, Dr. Prabhakaran sir is directly serving as professor at the Theory of Community Medicine at Chartered Medical College. He worked in details from BME Medical College and completed MD in Community Medicine from Narayana Medical College. His campus has multiple institutions, including Mara and Medical College, where he has held roles from senior president and professor. His expertise direct medical education, epidemiology, and health systems management, making him a valuable voice in shaping future public health leaders. Welcome, sir.
Okay.
Okay. Good morning again. So another 20 minutes I am going to cover respiratory diseases. I am covering in 30 minutes, but I will cut short. Okay. So I will cover systemic epidemiology. As ma'am covered general epidemiology, I am going to cover systemic epidemiology in first. So it's like a respiratory diseases. What are respiratory diseases? The diseases spreads through respiratory system or affected respiratory system. Right. Right. So what are the different modes of transmission of disease? What are the different modes of transmission? Attention, all of you. Attention, please. Attention, please. What are the different modes of transmission? Huh? Aerosol. Then anything else? Only aerosol. Okay, I'll say it. I'll do respectable. Any other groups? You know, blood product. Then body overall group. Okay. Direct contact. Okay, these are the different groups. Most of the respiratory diseases spread through droplet or aerosol transmission, affected through respiratory system. So common flow is that all the respiratory diseases we have vaccines. Most of the diseases we have vaccine. Most of the diseases we have incubation period between 5 to 10 days. See other diseases, those spread through skin or biological transmission, the incubation period is more than a week or months together. Right? But in case of respiratory disease, most of the diseases. So respiratory duration is very short, 5 to 10 days. All this, come here. Data problem. Okay. So what are the, because these are major public problem because it causes highest mortality and mortality. Right? So 23% of the cases in the hospital are respiratory diseases. Okay. So what are the diseases I'm going to cover? Each slide I will share 2 minutes. I only share the important parts. The must to know points to be I will share. So smallpox, chickenpox, measles, mumps, rubella. Okay, MMR. So can you name the vaccine code? MMR, DPT. Okay. What is diphtheria? Pertussis is not there. Influenza, meningococcal meningitis, ARI, SARS, COVID-19. So among those, which diseases we don't have vaccine? ARI is the common term. Influenza we have vaccine, meningococcal we have vaccine, COVID-19 we have vaccine. TB also we have positive vaccine, basically. So most of the diseases we have vaccine. Okay. Now first, so before we go to the disease, because most of the diseases we have some skin manifestations because it's an acute disease. All the diseases, most of these acute diseases, that's why the incubation periods are very less. So we have a lot of prodromal symptoms. All the viral diseases are having prodromal symptoms. It causes some rashes also. That's why we wanted to know the manual. What is the intensity, manual, acute, vesicle, and so when you see a case of measles, we should describe the lesion, whether it's an macular lesion or papular lesion or pustular. Okay, so that's why we need to know. So this is the only discoloration will be there, the flat skin will be there. Okay, no elevations will be there. It's a macule. The macule is also circumference elevated solid, maybe high than the skin surface, right? Less than 1 centimeter. This also less than 1 centimeter. This is a case of chicken pox. You have seen, no? So like this is a kind of thing. It contains 2 E. So that is called vesicle. It's also less than 0.5. Bulla is the bigger one. First two, in that vesicle we have ascites, right? Okay. So these are the terminologies we are going to use the skin rashes. Okay. Right. Smallpox caused by virus C, how it affected, right? So it is only disease eradicated in the world. Okay. First disease eradicated before 2000. So in 1980, WHO declared the smallpox was eradicated. Okay. Right. This is an important public health landmark in public health. Okay, that is smallpox. We move to next. Monkeypox, otherwise called Mpox. Mpox. So we see every macropotamiry. Okay. The lesions is like that. It's the spread through animal, rat, squirrels, dormant. So animal to human transmission, then human to human transmission also. Incubation period, see 6 to 13 days. Average 5 days fever. 6 to 13 days. Pain is a fever and lymphadenopathy. So one of the important feature in all the respiratory, only few diseases they have lymph node swelling. Okay, because most of the because swelling mostly by bacterial diseases we have lymphadenopathy. Few viral diseases that the lymphadenopathy, one among is this one, Mpox and diphtheria. Papule will be there. So this is the macule and papule. Okay, started with macule and the surface will be elevated, and papule also will be there. Treatment self-limiting, no vaccine or self-limiting only. Okay. Chickenpox caused by varicella zoster alpha virus, highly contagious, spread very fast. Okay. Then in incubation period, 14 to 16 days, but it spread fast. Like 1 to 2 days before and 4 to 5 days after rest. Secondary attack rate. What is secondary attack rate? Anyone? I will give chocolate. If anyone can the exact definition of secondary attack rate, I will give chocolate. Countdown starts. 1, 5, 1, 2, 3, 4, 5. Chocolate is for me. Okay, try. What is secondary attack rate? Anyone try? We don't want exact answer. Common way of sometimes governments also will ask. The name is there. Attack, what is attack rate? Again, this is the attack rate. 100 people is exposed. How many people got the disease in attack? Attention, attention, last group, one begin, hello, attention, stand up. Don't use the stand up. Second, last. Yeah. Tell me. 100 people are susceptible, 50 people got the disease. What is the attack rate? Out of 100 people, 50 got disease. What is the attack rate? 50, right? What do you mean by secondary attack rate? In that incubation period, all the other susceptible contact getting the disease. That is secondary attack rate. 6. So here the secondary attack rate is 83%. It's also a MCQ question. Secondary attack rate 83%. So the blister is the itchy blister. One important thing is pregnant chickenpox during pregnancy causes congenital varicella syndrome. Same like rubella, congenital rubella syndrome. Two diseases very peculiar. Chickenpox causes congenital varicella syndrome. Rubella, congenital rubella syndrome. We have vaccine, right? We have vaccine for children and adults. So varicella vaccine 12 to 18 months of children is should give along the chemoma. Above 30 years we should give 2 doses. So how many of you not got chickenpox? Raise your hands. யாருக்கு இது வரைக்கும் chickenpox வந்தது இல்லை? Okay, நிறைய பேர் இருக்கீங்க. Okay, சரி. Complications are important. What are the complications of chickenpox? Pneumonia, encephalitis, acute cerebral ataxia, Ray's syndrome, and hemorrhage. Most of the respiratory diseases complications are like pneumonia will be there, encephalitis will be there. Blindly, any examiner has what is the complications of this disease? We can try pneumonia, encephalitis. Mostly it will be. Okay. One important other thing is measles. Measles caused by measles virus. Measles virus. So what is the incubation period? 7 to 21 days. Second attack rate 80%. Describe the measles. Macular also there, papular also there. Papular actually there. There are 3 stages there. Prodromal symptoms. Prodromal symptoms, what are the symptoms? Itching, fever, headache. Next stage is eruptive stage. Right? Then it starts in the back of the neck. It will start, the spread is slow like this. Okay? Then ankle also given. When it starts from here, it will go like this. Also given. Then we have a post-nasal stage. It's a complication stage. Okay? So what is the vaccine for measles? Measles vaccination is given at the age of 9 months. Okay, 9 months. Always remember measles vaccination 9 months. MMR 1.5 years. Blindly you can remember 1.5 years. So 2 doses will be given. Efficacy of vaccine 95%. So additionally we should give vitamin A. We should give nutrition purpose only. What is the dose of vitamin A at the age of 1 year? Given here. 6 months to 1 year, 1 lakh. After 1 year, 2 lakh. What is the route of administration? Vitamin A? IV or IM? Oral. Okay, oral. What is the complications of measles? See, is there pneumonia coming? Pneumonia is there, diarrhea. It's a common MCQ question. What is the commonest complication of measles? Diarrhea. Okay, other complications also there. SSP is important one. SSP, subacute sclerosing and encephalitis. The type of encephalitis is a very serious complications. Another one important point in leprosy is the sign oblique spot. So oblique spot. What is oblique spot? Which molar will find opposite to lower molar, lower second molar. You will get, see, this is the oblique spot. Trace color cells will be there in the mouth. Okay, oblique spot means measles issue. Okay, upper cells 6 to common age is 6 months to 3 years. There is one campaign is there, India measles rubella campaign. Okay, the campaign is like 2021 to 2030. They have to eradicate the measles. Next mumps caused by myxovirus. Community 4 to 6 days and will be equal to 25 days. Parotitis swelling, second rate of rate 86%. So mumps, what we should remember? The swelling, right? Swelling is there in the neck. Complication, meningitis and otitis. Next one is important is rubella. rubella, otherwise called German measles. It affects less than 15 years. What is the etiology? Rubella virus. The spread of the incubation period 14 days. 14 days. Okay. So here I already told, right? If rubella vaccination given during pregnancy, what will happen? If rubella happen to the pregnancy, what is the complication will arise? Congenital rubella syndrome. So that's why there are campaign, MR campaign is there, measles rubella campaign. So before getting pregnancy, okay, 1 month before, we should wait for 1 month to get pregnant. So, and vaccination, the transmission also we should wait for 2 weeks. Okay. We should not transfuse immediately of the rubella vaccination. Right. Diphtheria. It's also one of the other is called coronary allergy. What is the diphtheria organism? Coronary bacteria. Is the bacteria virus? Where is the bacteria? Bacteria. Okay. What is the important sign there? What is called gray-white membrane leakage and pharyngeal region. There are 3 types of them: anterior, nasal, posterior, and laryngeal. Which one is very much serious? Anterior nasal. The severity is very high. So, which vaccination you should do? For diphtheria, DPT, or otherwise called second row. Last year, you know, Krishna. So, which vaccination we should give for diphtheria? DPT. DPT available in the public program in the name of pentavalent vaccination. But we have not covered vaccination because it's a common topic in epidemiology. We should know all the vaccination, the route of administration, the amount that we should give, what is the immediate complications. What is the complication of vaccination? There is a term called, what is the terminology that we use for vaccination? Side effects. Adverse effect following immunization. Yes, we should read because we don't have time to teach all the vaccination. What is side effect? Important side effect. Okay, complications, serious complications we should read. So DPT includes one of the serious complications. What serious complications will get? C-test. C-test. Okay, that's the serious complications. Okay, so when we give antitoxin, the cases will give antitoxin. Okay, for the contact we give diphtheria vaccine. So the antitoxin 20K unit will be given, penicillin will be there, carrier will be there. So what is the difference between carrier and contact? Carrier and carrier won't transmit or transmit. Contact won't transmit. The carrier will be one. What is the best example for carrier? One is diphtheria, another one is typhoid malaria. Okay, typhoid malaria. So we need isolation for diphtheria. It's a highly contagious disease, so we need isolation also. Potential diphtheria also there. Next, influenza. We read most of the diseases in microbiology, right? And there's an English fifth type of diphtheria: A, B, C, D. A, B causes epidemic. It's like it's also one of the MCQ question. Which disease is the truly international disease? Not COVID. This is the truly an international disease because it affects all the ages involved. Right, incubation period 1 to 4 days, fever, cough, sore throat. So what are the different types of influenza? Listen, another 5 minutes I will close. Bird flu H5N1, swine flu H1N. So which vaccination we should give? Yearly vaccination. Annual vaccination is recommended in case of flu vaccination. How many of you got flu vaccinated? No. So what? Okay. So every year, what is the complication of influenza? That is pneumonia. See, pneumonia is always there. You get pneumonia, high syndrome, fatty liver, encephalopathy. So that's how we got influenza. Another important disease, meningococcal meningitis. When a mother gave me, okay. So meningococcal meningitis, what is the organism? Neisseria meningitis. Epidemic, more than 100 cases, endemic, less than 100 cases per lakh population is given by WHO. So incubation period 3 to 4 days. Asymptomatic guide also there. What is the antibiotic we should give? Rifampicin. Penicillin won't work. In case of meningococcal meningitis, penicillin won't work. But other diseases, penicillin might work. So prevention control. What is the vaccination? Meningococcal vaccination we should give. So there are two types of vaccination, polysaccharide and polysaccharide protein conjugate. It contains all the ACW133 serotypes. Prophylactic antibiotics also we should give for close contact. Okay, that is meningococcal meningitis. Children, infant 3 to 12 months are commonly affected with this disease. Acute respiratory tract infection. Okay, acute respiratory tract infection. One side is not showing. Stop. In 5 minutes that it is talking. Acute respiratory tract infection. So caused by many viruses and bacteria, so that you can read from the book. Many bacteria viruses causing the disease, respiratory tract. So vaccination, all vaccinations, no, we all know, right? Measles, MMR, pentavalent, PPV, 23, PCV, so all vaccination. So the goal is also there internationally. International Global Action for Pneumonia is also there. IMNCA. So IMNCA is a common terminology that we use for childhood diseases. I only cover the pneumonia part, respiratory disease part. So there is a classification, right? Assess, classify, identify, treat, and refer. So this is the norm in IMCA. We should assess the patient, classify the patient, identify the patient. It is treat them, identify the diagnosis and treat the patient. So assess the things we should assess. So we have to check whether the person has convulsion. For 2 types they are given. Up to 2 months, one criteria, 2 months to 5 years another criteria. So less than 2 months, the person is having acute respiratory infection. So we should compulsorily refer. That's why there are 3 criteria given here. Pink means urgent referral. So less than 2 months, urgent referral. Any symptoms, convulsion, fast breathing, 60 breaths per minute at the 2 months age, should refer nasal flaring, grunting, bulging, pattern, and pustule, skin pustule, temperature is 37.5, lethargic, unconscious, abnormal movement. Immediately we should refer the case. That we should remember. Human side, if you find any case, should compulsorily refer that case. So 2 to 5 months, 2 months to 5 years. I'll finish in 5 minutes. or take to cover SARS, COVID-19 and TB. Okay, I should cover in 5 minutes. COVID, everyone knows, right? COVID. What is the causative organism for COVID? Ma, please don't know. Interested is what is the causative organism of the COVID? Auto-driver will also tell us. SARS-CoV, 1 or 2? 2. Okay. Thank you. So, what is the incubation period of COVID-19? What is the incubation period? 7 to 14 days. Okay. What is the symptoms of COVID? Second. Okay. So 2 months to 5 years, 3 categories are there. Pink, yellow, and green. So what is the rate 2 months to 12 months? 50 pellets per minute. 50 ml which should refer. So 12 months to 5 years, 40 pellets per minute is the normal cutoff. Okay. So any general danger signs history including straighter and form cell, you should refer the case. Fulfill the injection. Okay. So fast breathing. So it is severe pneumonia, no pneumonia. Severe pneumonia, no pneumonia. Severe pneumonia, danger signs we should tell. So pneumonia only fast breathing. Apart from other symptoms, fast breathing will be there. The no pneumonia, no signs, no severe disease. So only we can give some symptomatic treatment. But pneumonia, we should give antibiotic. SARS caused by SARS-CoV-1. This also insignificant, should be quarantine is there. COVID-19, what is the quarantine period? Incubation period 2 to 40 days. Prevention control. What are the vaccination for COVID? Name of the vaccine? Vaccine. Covishield, Sputnik. So what are the variants? Virus strain, beta type, alpha, delta, omicron. Omicron, kindly remember that term B11529. Commonly we are asking the MCQ type. What is the variant of omicron? B11529, you should remember. Many others you know. Then we tuberculosis. So what is the presumptive TB? 45% TB. There is some 5 symptoms of presumptive TB. I will give chocolate. Except 5. Cough. Presumptive there are 2 types. Presumptive drug sensitive TB. Presumptive drug resistant TB. Presumptive drug sensitive TB. Anyone 10, 4 or 5 symptoms. Last stand up. Yani presumptive pulmonary TB. What are the symptoms? This called suspect. Yaar வந்து suspect பண்ணுங்க indication. என்ன suspect பண்ணிக்கலாம்? Sir, tell me one point one. Next one. Okay. Second one. Cough. Chronic cough. Chronic cough. Weight loss. Okay, weight loss morning. This is the percentage community medicine. TB importance. Fourth one. Inflammation. சொன்னமா சொல்லுங்க பாருங்க. என்னமா சொன்ன? Okay. Okay. Anything else? Okay, say, don't disturb others. Okay, cough more than 2 weeks, hemoptysis, fever more than 2 weeks, weight loss, significant weight loss, pulmonary abdominal result, presumably BP, presumably EP to B, swelling, discharge, presumably pediatric BP. Hey, you walk me. Walk. Second row, third row, second one. Second knee. End. Come front. And where you? Okay, so presently pediatric TB, all symptoms will be there instead of weight loss, poor weight gain you should have. So presently DRTB, so all failed treatment to first line drugs. Okay, previously treated TB, actually with HIV infection, pediatric TB non-responders are considered presently DRTB. There are two types of TB, right? What are the two types of TB? How many types of TB do you know? All TB classes are over. It's a medicine class, but they are taking like this. Because your performance is very poor. 50% of these students are failing in the assessment. Tell me how many types of TB do you know? Hey, நான் கேள்விக்கிட்டேன்ப்பா என்னை பாரு எங்க பார்த்துருக்க மல்டிகிராம் ரெசிஸ்டன்ஸ் டிபி அப்புறம் extensive and resistant TB. What is multi-drug resistant TB? Multiple drugs. How clear? How clear? First line all was drug failure. Okay. Then extensive drug resistant. Second line eல்லாம் failure. Okay, two types of TB based on diagnosis. Microbiologically confirmed TB. Any microbiologically diagnosed for present-day TB patient, diagnosed microbiologically, we find out the TB basically in the sample. We determine the microbiologically confirmed TB, either in a sputum or molecular test. Clinically diagnosed all microbiologically negative, but they have the TB symptoms. But clinician decides the patient might have TB, they treat. That is called clinically diagnosed TB. Apart from that, what are the other types you know? Drug sensitive, drug resistant. You tell like that. Drug sensitive TB, drug resistant TB, pulmonary TB, extrapulmonary TB. You know. Tests. Microscopy, CG and gene expert, Brunat, culture, solid, liquid culture. These many tests are there in microbiology tests. Supporting test is X-ray. This is screening test for TB, histopathology, and for EBP. Growth-based culture, molecular-based CDNet, Brunat, and the LPA, line probe assay. So this algorithm, I don't have time. So everyone should know the algorithm. Definitely, we get some essay question to this. All algorithm you must know. All the person will be you must know the algorithm. What is 4S screening? For all IRIS groups, the 4 symptoms we will identify to screen the patient. That is verbal screening. Okay, that is verbal screening. That all present symptoms, right? Cough more than 2 weeks, fever more than 2 weeks, weight loss, and night sweat. The 4 symptoms anybody there, we should rule out active TB. If no symptom is there, we do for PSC. I already told right, every Indian is a tuberculosis patient. Nearly 60 to 70% of the patients are affected by the TB infection. So TB infection. So how to find out the TB infection? What test we should do? Interferon gamma releasing assay or skin test, not tuberculosis test. Side TB, COT, side TB we should do. After 2 days, we should check for the inhalation more than 5 millimeter. We tell the person is a TB infected person. But in TB disease person will be possible. That's why you have to take the sputum or X-ray test. If X-ray negative, IGRA positive means the Indian is a TB infected person. The TB tests are positive, TB disease. Okay. Another two slides I will concentrate. This statement you all know, HRND or HRE. We are giving FDC, fixed dose combination, FDC, based on the weight plan, they will give, in a question. What is the problem? Don't they convey anything to the group or me? So based on the weight plan, the patient is 25 to 34, 2 tablets will be given. In the one tablet itself, all the medicine, the last row, the moon pay return. Now what are we showing to them? Class is happening here. Why are you referring the books? Are you checking? Am I telling correctly or not? Okay, that is FDC. So, what is the preventive therapy? TB preventive therapy, 2 medicines we are giving, ICNC and 3HP regimen. What is the regimen? What is the medicine that we are using in 3HP? Rifampicin. Rifampicin plus ICNC. BP dose for 3 months which should cure. Okay, before one step, it's not sorry. Two more slides. Yes. So all of you must know this categorization. All of you. Okay, all of you should memorize this. Group A drug, Group B drug, Group C drug. Group A drug, we have levofloxacin, bedaquiline, linezolid. Okay. Group B, clobazam, cyclosporine. Group C, other drugs, ethanol, niacinamide, pyrizinamide, amlodipine, salicylic acid, everything is there. So this is an importance. Okay. So A, B, C, you should remember. Based on that, we are defining the DRTP. MDRTP is MTP resistance to isoniazid rifampicin. These 2 first line vaccine, not all the drugs. They are not testing all the drugs with the other drugs. Only 2 important drugs they are testing. First one is rifampicin. So through CBNAC, can we test rifampicin? What is the advantage of CBNAC? Or gene expert? Or TrueNAC? We are dealing with the TB disease. We are dealing with the drug resistant and rifampicin at least. But other drugs also we have provisions, but at least rifampicin we can test. So 3XCR, another name is called 3XCR. So MDR-TB plus 1 fluoroquinolone. Either levofloxacin or oxyfloxacin. That is called 3XCR before one stage of XCR. So MDR means rifampicin pyrizinamide. X3XCR means rifampicin pyrizinamide fluoroquinolone. So later one is XCR. Later one is XCR. The other means rifampicin fluoroquinolone plus group A drugs. Okay, that's why I wanted to memorize the group A drugs. What are the group A drugs? Bedaquiline, linezolid are both. That is the definition of MDR-TB. This one, MDR regimen in one slide. Okay. Short and oral regimen is a new regimen. Okay. Any patient with DRTB less than 14 years is into B-Barlow regimen. B-Barlow regimen. Bedaquiline containing regimen. Okay. H monopoly. Only isoniazid resistance is there. Because there is no resistance. Instead of isoniazid, we are giving levofloxacin for 6 to 9 months. So, shorter oral MDR regimen 9 to 11 months. Intensive phase 4 to 6 months. Continuous 5 months. All oral combination 8 to 20 months. So this one over. Last slide. Patient support mechanism. All the TB patients is given rupees 1,000 rupees per month. That is called mixed portion use. For nutrition purpose, government is giving 1,000 rupees to the patient in the back of month. That is DBD, direct benefit transfer. Okay, or till the completion of the treatment, 6 months or 9 months or 2 years, whichever the doctor says, the government is giving person is not only patient, doctor also giving the money. So say 500 rupees on notification. It is a notification disease. The doctor notifies the disease, the doctor gets 500. Doctor confirms the patient completed the treatment or cured. He will doctor will be given 500 rupees. So doctor gets 1,000 rupees, patient gets 3 months 6,000 rupees for one piece of TB. One patient in lifetime 15 cases is transmitted. Lifetime one TB patient transmit 15 TB disease. TB infected maybe many. Like another thing is for ASHA, a treatment supporter, will be given 1,000 rupees for the treatment support. For MDR 5,000, government is giving 5,000 rupees. Okay, that's all about my session. Okay, about respiratory disease in a short. Okay, those respiratory disease are very, very important diseases. So remember all the information and clinical research, prevention and control. All the communicable diseases in SL at the end, you should write prevention control. In the prevention control, you should write medicine health education and vaccination. Okay, that is very important. Any other seconds? Always, please.
Now, it's my honor to welcome Dr. Ramesh sir, who will now share valuable insights on topic gastrointestinal tract, STD, and AIDS. Welcome, sir.
Good afternoon, everybody. I finished in 20 minutes, as Sarah told. So, today's topic is gastrointestinal tract system infections, STD and NG. So, as you all know, the in epidemiology, we got total of entry and total of exits. So, those infections, it is not the direct infections. So, how the organisms are entering into the body, and even though some infections enter the body through the gastrointestinal route, sometimes they have got a connection to the nervous system, as in poliomyelitis, and also so this is gastrointestinal mainly how the injury and total of entry and total of exit. So based on that. So, intestinal infections are of public health importance. So, we have got different types of microorganisms that we have always studied. One is viral agents. These are many of the endemic viruses. Studying all these things were microbiology. And some are blood-borne infections. So, they don't enter to the gastrointestinal tract, but they affect the liver through the blood. So, blood-borne viruses like hepatitis C, hepatitis C, some of the hepatitis viruses like hepatitis A, hepatitis E, enter to the gastrointestinal tract and affect the liver. Then certain bacteria like E. coli, Shigella, all these enter, and protozoa, entomology, Giardia, Cyclospora, Vector-borne, all these things, and soil transmitted proteins. So, soil transfer includes rodents, ascaris, worms, those species, Ancylostoma, Biodinate, and Cavula americanus, Bigworm, Trichotis flagella, and threadworm, strong rights, Streptovirus. So, these are the group of viruses. So, different types of viruses that affect the endemic system. So, most of the see the virus. Some of the virus, for example, adenovirus mainly can produce gastrointestinal as well as respiratory diseases, conjunctivitis. That is why certain virus infection will be tearing of the eyes, to emphasize on the reasons. Enterovirus, gastroenteritis, meningitis, gastroenteritis, vomiting and diarrhea. That is called as gastroenteritis, vomiting and diarrhea. Myocarditis, poliovirus, meningitis, and encephalitis, oxalic virus, and rotavirus and astrovirus, gastroenteritis, hepatitis, A virus, B, hepatitis, and norovirus, gastroenteritis. So these are different types of enteric viruses. Poliomyelitis. In the past, 1988, World Health Assembly made a resolution for the global polio eradication. In 1990s, India was hyperepidemic for polio. About 500 to 1,000 children were getting paralyzed. In 9th December 1995 and 20th January 1996, the first pulse polio immunization program was started. And in 1977, the national polio surveillance project and acute classic paralysis surveillance and surveillance medical officers were recruited. In 1999, the London pulse polio immunization activity was converted into a three-day activity that is called as intensified pulse polio immunization. And the last years of wild poliovirus was reported Aligarh and UP. And in 2000, the clinical, from the clinical to viral system classification of AFP cases, in 2001, environmental sampling of wild poliovirus was started in Bombay, and then the seabed samples were finished. And in 2005, and in 2010, last year the wild poliovirus was reported in Jharkhand, and 2010 and 12, several global studies was done in UP and Bihar. In 2011, the last case of wild poliovirus was reported in Aura, and 2012, India's state was removed from WHO from the list of polio-endemic countries. In 2013, polio eradication NPO strategic plan, and in 2013, India has been certified polio-free by the World Health Organization. And in 2022, states polio eradication strategy were to prevent the transmission of polio from endemic to non-endemic countries. So polio is the future. The annual polio campaigns on national immunization days will be conducted on some national immunization days to keep the immunity levels high, surveillance and vaccination, and new vaccines and expansion of the epidemic. You see the eradication phase, the eradication phase, only able to poliovirus was yes, only able to vaccine virus was 100%, but the vaccine use was OPD. In eradication phase, while polio linked to poliovirus, no, while polio linked to vaccine virus yes, we started OPD and ITD. In eradication phase 2, while poliovirus no, polio linked to vaccine virus no, and that vaccine to be used solely ITD. And post eradication, no wild poliovirus, no vaccine virus, and no vaccines will be given. So India is the team to give a state of eradication of polio, and the constant efforts by many of the people who are by polio eradication. So whether hepatitis, you see hepatitis B and hepatitis C present a significant public health challenge leading to chronic liver disease and hepatocellular carcinoma. And the government of India started the National Viral Hepatitis Control Program in 2018. And as per the data, hepatitis C is prevalent in India and is more prevalent in rural areas, and hepatitis C is more prevalent in urban areas. So the 5 key evidence, so one of the countries, the world Egypt, they were able to eliminate hepatitis C, even without a vaccine program. So vaccine against hepatitis C is not there, but the vaccine for hepatitis B is present. Even though the virus vaccine is not there, the Egypt country has able to eliminate into these strategies. So one is by constant epidemiological surveillance, robust public health infrastructure, political will and financial commitment, inclusive healthcare and cost. So include all and affordable and accessible testing and treatment. So these were the 5 elements by which they were able to eliminate. The Egypt was able to eliminate hepatitis C. So, when you are testing hepatitis C, the WHO organization has told 5 C's. One is you have to get the consent. Second is you have to maintain the confidentiality. Third is you have to give the correct test results. Fourth is counseling. And fifth is connection and links to prevention, treatment, and care services. So, National Hepatitis Control Program, we have a 20 component, which includes the awareness generation, immunization, safety of related health projects, injection safety, and safe drinking water. Second is diagnosis and treatment, screening of pregnant mothers, referral from institutional deliveries, and vaccination of birth dose. So when we give the birth dose of hepatitis B, we prevent the child becoming a carrier for hepatitis B. So that is the significance of giving the birth dose of hepatitis. At 0 dose, you are giving hepatitis B vaccine to prevent the child from becoming a carrier state. So free screening and diagnosis, prevention of lineages and community support. Third is with monitoring and evaluation, surveillance and surveillance system, fifth is organizational research, training and capacity. Typhoid fever. So typhoid fever in 1880s is a local disease called Salmonella typhi. Common but serious disease that affect mostly children, adolescents, and even adults. The main source of the stool and the urine of infected persons, and the foods were lucky in the preparation of food are maybe a very good carrier. We were learning about typhoid mainly in the US where Secret was able to infect many people to produce pain. And it is one of the disease 8.3 million cases and 72,000 deaths have occurred. So clinical presentation is usually incubation with 1 to 4 days, 14 days, non-specific symptoms like chills, persistent headache, abdominal discomfort, constipation, diarrhea, weakness. So the typical symptoms are abdomen, high fever, pain in the abdomen, high fever, and maybe the important presenting symptoms. So diagnosis of in endemic and resource poor means clinical diagnosis of typhoid fever is often more inaccurate as a difference over the diagnostic test. However, the clinical diagnosis is difficult because the occurrence of co-endemic and acute febrile illness. Importantly, accurate laboratory diagnosis reveals the true burden which initiates appropriate therapeutics. And also it prevents the emergence of antimicrobial resistance. So prevention, you have to have a robust surveillance system. Water, sanitation, hygiene is very important. So you are able to clean water, sanitation, hygiene, majority of the thing can be and early and correct diagnosis by viral test. Viral test also is not so sensitive, and there are many other tests have been but some are very costly culture and prompt treatment and also vaccination using typhoid conjugate vaccines. So very important sometimes typhoid conjugate vaccine may be one of the best solution to tackle the problem of this typhoid fever. Intestinal parasitic infections. Around 21% of India's population may be affected by intestinal parasites. The most widespread parasites are Ascaris lumbricoides, Pityris fistula, and Hymenopteris and Hymenopteris nana. It's called as dark tapeworm and protozoan like Giardia lamblia. So it is a neglected tropical disease. So neglected tropical disease, and India in particular contributes to the global burden of 21%. The high prevalence of soil transmitted disease has been mainly due to the significant poverty. The soil transmitted disease means they require a soil so for the development of the next stage. So if you are preventing soil pollution by preventing open edification, the soil transmitted disease can be prevented. That is the importance of construction of sanitary latrine and proper disposal of fecal matter. So maybe the preschool and school age children are maybe affected by this disease. So control is by mass drug administration or using albendazole on reloading days are observed in February 10th and as well as August 10th. We are observing and national reloading days are observed. So one of the important thing is the sanitation barrier. So field, flies, windows, bridge. So 5 years, we are able to control nuclear contact with the feces, and in the food, we can prevent most of the infections due to intestinal infections. We will see an outbreak of investigation of foodborne illness in Kannur. So, in food poisoning, in 2015, a foodborne outbreak was investigated in the Kannur district among the political rally people, and they developed after consuming lemon rice and other food items, they developed the diarrhea and vomiting. So that was epidemic drug of 42 foodborne illness cases that were reported after consumption. So they did a cohort analysis and they found out how many of them took lemon rice and they found out that they took the lemon fruits were taken for lunch as well as for dinner. But if you see the people who are exposed were 4. So 4.2 who consume people who consume lemon rice during dinner are more responsible for the cause for food poisoning outbreak. So this is how we arrive at the investigation of food poisoning outbreak. So the final conclusion, and they found that they were using this preparation of in the flavor. So in that along with the grass, they used this and bacillus cereus was one of the bacteria that was responsible for the food poisoning, and this will lead to the diagnosis of food poisoning. This is how they come to conclusion. World Water Day, 29th July is realized as the World Water Day, and ORD was developed in 1960 by a researcher at the International Center for Diarrheal Disease and Diarrheal Diseases and Research in Bangladesh. And one of our Indian scientists, Dr. Dilip Mahavnadesh, was an Indian doctor who worked in the refugee camps of the Indian Pakistan war. He used, instead of using IV fluids, he developed this ORS, ORD, and this led to the decreases the deaths of diarrhea. So this is the different types of ORS that is used, and Reservoir is one of the ORS that is used for malnourished children. And this is the standard ORS, and we use osmolarity ORS. Sexually transmitted diseases, if you see, since the diagnosis is very difficult, lab tests are required. The government of India or the World Health Organization started this syndromic management of sexually transmitted diseases. And but one of the important problems this sexually transmitted designated sexually transmitted or reproductive tract infection clinics are known as Suraksha Clinic as per the National AIDS Program, AIDS Control Program. And these are the common sexually transmitted diseases that are common affecting the people. And the 7 C's in the syndromic management is one is the client satisfaction, chemical treatment with the proper antibiotics, counseling and education of the patient, contact promotion, comprehensive treatment, contact tracing, and partner management, and combined for follow-up. So these are the color coded kits for the different syndromes for and the drugs that are used, and different color codes are given to them. So one of the important drawbacks in the syndromic management is that it is not able to tackle the asymptomatic infections. Asymptomatic infections, people with asymptomatic infections may still be able to transmit the infection to others. So that's one of the drawbacks in the syndromic management of STDs. So what to do about this? HIV. So one of the important is the 95 target. It's a human AIDS 680, which aids to end HIV epidemic and AIDS as a public threat by glucose. So 95% should be aware of HIV diagnosis, 95% should be treated for HIV, and 95% should be widely suppressed. So Sampurna Suraksha strategy is one of the strategies to prevent, and this has been existing. Sampurna is replacing the ICGC and the STD and reproductive trainings as Sampurna Suraksha facilities. Thank you.
Thank you, sir, for gracing us with your message. Now, I would like to call on Dr. Prabhakaran, sir, to felicitate Dr. For the next section, with great pleasure, I invite Dr. Swati Panichami Madam, who is a senior resident in Community Medicine.
I think the lunch break I'm having with the time of shortage and all, I'll take just 10 minutes and rush to it. I'll share the slides and then all 2 points for all your program will be easy for your revision. So I'll just going through the slide. I will not be taking more than 10 minutes with me one. I'll be taking you by one. And moving on to the indicators, you know what are the indicators, important indicators in RCS, right? I'll say what are the new things that we did about. Yeah, the current IMR is 27, it was 28,000 live births previously. It's 27,000 live births as of now. And other than that, anything I have to change. Coming to the maternal mortality ratio, the old is 97,000, 97 per 1 lakh live birth. Now it is 93 per 1 lakh live birth. So keep in mind that like IMR and MMR have been changed. All of you will be knowing what are the minimal code activities for all these things. Lower weight, just getting over less than 2.5 grams, that's 2.5 kg is known as lower weight. Whereas when it is less than 1,500 grams, very lower weight, and less than 1,000 grams is extremely lower weight. The most common causes will be like babies and like small for gestation. The treatment is starting at ICU admission and KMC, but you'll be doing another category. And what will be the NTP management for lower weight? So get to know that if the baby is less than 2 kg, you will have to take into the ICU, that is NICU or ICU, and you'll be monitoring until they are getting their cancer growth. That is, they will be having regular growth. We have also like start 38 weeks, start is about completed weeks to less than 42 weeks. Post-term will be more than 42 weeks and pre-term will be less than 37 weeks. For scale, get to know what is extremely pre-term and very pre-term and moderate pre-term also. And all these programs, like a very friendly hospital, I have given pneumonic, I will send you what is the pneumonic expect baby. And you are seeing F1 and F1 will be known about F1 it recently it's getting all the attention to it. So all these things I'll be sharing with you. You can go through it or every program are in 4 lines here. And the essential also is important CMOM and CMOM will also be important for your exams. And RMCH all these programs are studying in RCH will be continuing under RMCH plus N. So if they are asking you, just remember why you have to write continuum of care because from the mother's adolescent age to the child adolescent age, you will be providing all the components here, which will be reproductive, maternal, neonatal, child adolescent, as MS supplement nutrition component. It's the newly added nutrition component. And in Japanese or China, I have to be reading everything. There is no change in all these programs. You also newborn care, you will declare the 6 number of visits. Remember, homemade newborn care, it will be in days. In child, it will be in months. So don't get confused between newborn care and child care. It's not normal adolescent reproductive and sexual health. It's not adolescent friendly health clinics. Don't write as nowadays. In INFP is nothing but it is to reduce NMR, neonatal mortality rate and stillbirth rate for less than 10 minutes, nothing but single digit. Other than FPG code, they are asked about INFP. Just mention this point. Other than that, you can write all about other programs and whatever regarding childhood. Here, Epidemiology and facility based newborn care, everything will be coming under INFP. The PM SMA, yeah, you'll be doing clinics, your manual clinics will be on 9th of every month. They will be color coded. Remember the colors and all. Blue, red, green, and all the colors. You have to read about the colors. At least write the 4 points when they are asking the program over, like all these programs. The only changes with PMV, right? Yeah, it was 3 installments. It was 3 installments before. It has changed to 2 installments. In the first installment, you'll be giving 3,000. In the second installment, you'll be giving 2,000. 3,000 when you complete your registration, and then you have to have at least 1% within the 6 months of pregnancy. In the second installment, you'll be getting 2,000 rupees after the registration of the child birth and first dose of vaccination. First dose of vaccination is not in birth dose. It is at the 6 weeks you'll be getting the dose one of everything is right. So that after completing it only you'll be getting 2,000. And the other one is for every second female child, at the single installment you'll be getting 6,000. And the PMVY. Integrated like IMC has been taught by SRA and Lakshmi is including the labor room quality. And the 3-village model is like, I think you have known all these 3-village models now, right? ICDS, I think I'm not having many time to cover, so 3 about ICDS and IVCF and all these 6 points are in your IVCF, all these things. And intensified thyroid control, it's nothing but you'll be having an ORS, you'll be distributing ORS to all the patients, their contact will be going to household visit in KFPSC. You'll be having an ORS format and you'll be distributing ORS, you'll be monitoring each season. Because you'll be having this program during monthly monsoon season to prevent the diarrhea. Because the diarrhea has a major cause of death under children. And anemia of blood, that is 666 strategy, you'll be having made it all that. But remember the tablet colors. For pregnant women, lactating women, and reproductive women, it's red color. For adolescent, that is adolescent, getting all the adolescents is 10 to 19 years of age. It's not like 18 or something. Everyone has written wrongly. 10 to 19 is adolescent. For adolescent, it will be like 60 mg of and 5 mg microgram of folic acid. The same dosage of color, but the tablet color will be blue. Whereas for school, like 5 to 10 years, the tablet will be pink color. The dosage will be 45 mg and 400 mg of folic acid. Whereas in 6 months to less than 5 years, you will be giving drops. So the drops will be having 20 mg iron and 100 mg folic acid. Deworming same, more than 6 months you will be giving, more than 6 months to 200, 2 years you will be giving 200 mg, only half tablet, that is not 200 mg of albendazole. So if albendazole tablet until from 6 months to 2 years you will be giving half tablets, from more than 2 years as an adult dose you will be giving a single tablet. And remember that the deworming days is on 10th February and 10th of August of every year. Family planning program, see, eligible couple is any couple. See, only after reproductive age group only not it will be getting married. Any woman will be married only to their reproductive age group. That is legal. So 18 to 49. So every woman in the reproductive age group will be coming as an eligible woman, eligible couple. Here contraception is given. Whereas the target couple is back, the person will not complete the family. Actually, they will be having one child. Back 7 can be done. And here, I think we are like PWO failure of contraception. So you will know the formula, read about the formulas, and temporary method formula method. I think you will get to know about all that. In IUDs, remember that copper 380 and copper 375 multiple device are only which is two device are only provided in half DMC. These are only free of cost. Government of India. Other than that, all these are will be recommended. In oral contraceptives, Mala N and Mala D is there. Mala N only is free of cost. OCT, but Mala D is will be given with a minimal cost. Injectables are DMPK, which is having the Vector-borne which is available in Government of India as Anzara. And Centron, we don't Centron also, it's one hormonal pill, which is available in India and it is also developed in India from Central Drug Research Institute, Uttar Pradesh. So remember that. And vasectomy is not standard vasectomy and vasectomy is modified provide further. Remember, 2 points you have to remember about vasectomy is that it's post op, what are the post operatives you have to use. For next 15 days, you shouldn't let's say any heavy weight, and for 3 months, they have to use barrier methods because after even after epidemiology, there will be some strong ingredient in it. And also that they will into pregnancy. So that for taking you have to accompany with condom along with it for 2 to 3 months or at least start the ejaculations. Easily you know what is vector which will be available in the government settings. And in national family program, 2 things you have to remember. One is mission Karnataka and Nani this mission Karnataka is starting with 86 contraceptives to every woman in the reproductive age group. In Nani is starting with newly married couples will be getting contraceptives. The contraceptives of choice for newly married women is OCDs. All these incentives they will be getting incentives and all. Okay, coming to MTP. Lot definitely remember about MTP when we were doing MTP and all. It's like amendment, there is 2 amendments happening. The MTP Act was it was established from 1972, but there are 2015